the second day of MRDCON 2024. Even today, we have a packed schedule with a variety of academic sessions and panel discussions lined up. I encourage you to actively participate, ask questions, and engage with your fellow attendees and share experiences. Let's make the most of this last day of the program and expand our horizon of knowledge and understanding in the field of medical oncology. I wish you a productive and enriching day ahead. The first session for today is a panel discussion on targeting MRD in AML: who, what, when, and where. For this session, may I ask the chairpersons to kindly be on stage. Dr. Rajat Bhattacharya, Senior Consultant, Pediatric Hematology, Apollo Cancer Center, Kolkata. Welcome, sir. May I also ask our other chairperson, Dr. Nitin Sood, to come on stage, please. Dr. Sood is Senior Director, Bone Marrow Transplant, Medanta, Gurugram. Welcome, sir. Now, may I request the chairpersons to kindly introduce the moderator and the panelists to the audience, handing over the session to the chairpersons. Thank you.
Good morning. So we welcome you for this morning session. And so it's on targeting MRD in AML, what, who, what, when, and where basis. So our moderator is Samir. Samir, please take your seat. Yeah, Samir is in Kokilaban. Is that right, Samir?
That's
yeah,
correct. That's correct.
And
Hello.
Yeah. Samir, you're going. Do you want to introduce the panelists or?
Yeah, I've got a list of names, so I can call
sure.
them up.
Please go ahead.
So good morning, everyone, and welcome to the second day of this MRDCON. Yesterday we had a quite engaging sessions on MRD, and we had I think Sumit Gujral, who spoke about methodologies, especially flow cytometry in AML. And my topic is targeting MRD. So I'll be speaking MRD in general. We have a bunch of quite distinguished panelists. We will be discussing 4 cases. And it is basically to see how each one of them would treat those patients, at what time points they would do their MRD. Would it be useful? Wouldn't it be useful? And we get a sort of a sense of how MRD is being used in AML. So I'd like to invite our panelists, Dr. Shruvanil Ball from Kolkata, Dr. Natraj KS from Bengaluru, Dr. Shilpa Bhartiya, Kolkata, Dr. Rajesh Malik Gotipati from Vijayawada, and Dr. Gaurav Khare. I think Gaurav's not here either. So welcome, panelists. So considerable progress has been made in the past several years in the scientific understanding of and available treatments of acute myeloid leukemia. Achievement of a conventional remission evaluated cytomorphologically via a small marrow sample is necessary but not sufficient step towards a cure. It is increasingly appreciated that molecular or immunophenotypic methods to identify and quantify measurable residual disease populations of leukemic cells below the cytomorphological detection limit provide refined information of the quality of response to treatment and the prediction of the risk of AML recurrence and leukemia-related deaths. So I think that's the background of why we want to do MRD in AML and how we can improve it. The prototype of MRD we all know is CML, also APML, where we're using molecular techniques and we can confidently say how the patient is doing and whether the patient is going to relapse or not. And sort of similar things we want to apply to other areas in hematology, AML being one of the most leading diseases out there. And this is American data. So it's a busy slide. If you look on your left, do I have a pointer here? Okay. Okay, if you look at this one, this is your AML outcomes over decades, and this is age less than 60. The blue line is down below is 1970s, and the pink line on top is 2010s. So you can see over the decades, the outcomes of AML are improving, but still the 5-year survival is still about, you can say it's about 55%, even in the 2010s. Now that is a, yeah, so this is 2010s, this is your 1970s. And you can see that over the decades, the AML outcomes have improved, but still the 5-year survival is still about sort of 55 to sort of 60%. And these are non-APL AMLs. So still a lot needs to be done. In contrast, when you see this, this is over 60s. Although over decades it has improved, but if you look at the less than 60, still a lot of work still needs to be done. Now contrast this to, this is again American data. This is, you can see this is 2013 onwards till sort of 2020. And this is divided by age. So if you now combine the less than 60, which is the sort of the green and the red together, we are sort of similarly there, inching towards probably 60%, and the more than 60 is still languishing below. So even now, looking at the American data, the non-APL, the outcomes are still about, you could say the best about 60%, 55 to 60%. And now we're looking at how MRD can improve that even further. Now, this is the ELN guidelines 2022 for management diagnosis of AML, and even the diagnostic criteria, the blast percentages are getting refined. So now traditionally we had AML, which was more than 20% blasts, but now there are entities like MDS, AML, or whether you had a specific genetic abnormalities, it would allow you to have a blast count more than 10% with that genetic abnormality to be called AML. So things are getting even more refined. The threshold where you would say AML is changing depending upon the mutations you're getting. And therefore, when we say that the person is cured or is in remission or is in molecular remission, it's important to know which genetic or molecular abnormality is associated with that particular AML and how you could best target it, either therapeutically or to monitor the responses associated with treatment to that AML. Now, since we have so many mutations, this is again the ELN risk stratification. Earlier on, you could remember that we just had the standard 821 inversion 16 with probably NPN1 with or without FLT3. But as the number of mutations and NGS have come up, you can see a whole host. You could look at this. There's a mutated ASXL. All these mutations, which we do in the NGS panel, come as adverse risk. And with the whole host of these genetic and molecular abnormalities, it therefore follows that when we have a patient with AML with us, the diagnostic array of tools and the number of diagnostic tests therefore increase. And it is up to us to decide which of these tests are going to be relevant to our patient in a particular age group and what we're going to do. So we're going to discuss all of these with our panelists. Shortly on the heels of the AML diagnostics update, we had the 2021 update on MRD, which took all of this into consideration, and they discussed the various methodologies available for MRD testing. And I would encourage everyone to look at this paper. It's a very good paper to go through the various diagnostic modalities and what should be targeted by which method. Now, if you look at the basic methodologies, you've got morphology, you've got flow cytometry, you've got the PCR, and then your NGS sequencing. And then you've got the levels of detection. So morphology sort of 10 raised to -2. Your flow cytometry probably goes to -3, can go even deeper. your PCR up to 10 raised to -5, and then the deeper sequencing, your NGS can go up to -7. So just MRD negative doesn't mean absence of disease. It really depends on the level of detection, the lower level of detection of that particular assay that you're using and the methodology, which needs to be quite standardized. So does this MRD actually have an impact? Now, this is a meta-analysis of over 10,000 patients in the United States and worldwide. They've looked at about 70 odd publications where they've looked at MRD, but this is MRD by flow and PCR combined. And they've looked at the data. So looking at overall survival and disease-free survival. And you can see that the lines are quite significant. So those who are MRD negative, you look at this, your overall survival is 65-year survival. We're talking of 5-year survival is 68%, and your disease-free survival is 64%, and MRD positive is in the 30s and 25%. So this graph cannot stress enough the importance of MRD testing in your patient for better outcomes. So with that, we come to our first case. Anyone can take this case. These are all cases that we see in our day-to-day practice. So there's nothing. So we got a 28-year-old engineer who's fit. There's no comorbidities. Recently diagnosed AML. Flow cytometry shows just standard myeloid markers. There are no aberrant lymphoid markers or anything of that sort. Normal karyotyping. NPM1 PCR is positive. So FLT3 PCR is negative. And there's no NGS done at that point. So I think simple questions. Does he need any more investigations? And if so, why? How would you treat? And will you measure MRD? When? By what method? So these are all just standard questions that we tend to look at in our day-to-day practice. So open to the panelists, to anyone who wants to take these questions.
Hello, yeah. So can I just go back to that first slide?
Sure.
Yeah. Yeah, so he's a young boy, fit, no comorbidities, AML, standard myeloid markers, NPM1 positive, and NGS was not done. So with the data that you have, he falls into the good risk with the NPM and but normal karyotyping with NPM, but without FLT3. So you'd fall into the good risk. NGS is not done. So if your next question, what you're asking, what other test needs to be done in this era, I think NGS needs to be done, because if NPM is an isolated abnormality, his risk group will be different. If it falls with other abnormalities, additional molecular markers are positive, then obviously the risk group will change. If that has not been done, the next question was, how is he going to be treated? He should be treated with a standard AML induction. Intensive induction is what I would prefer to do in him. And then, of course, after the end of induction, we'll want to see. So, you want the whole sort of sequence for me to tell?
Just go on what you do here.
So you would give him induction DA 3+7. At the end of induction, I would check his entire panel again. I would do his morphological blast remission, flow cytometry. At that point, it is not necessary. I would say I would do MRD at the very first. In a practical purpose, I would probably not do it, but I would check his NPM, PCR, and cytogenetics again at the first time point. If with the data we had and we were never going to do NGS, he would probably not be a candidate for transplant at this stage. So when would you measure MRD? I would measure his MRD at the end of my consolidation treatment. I would do it by PCR as well as by flow, although you don't have you do have no aberrant markers, but definitely from what his leukemia phenotype was, I would do an MRD by flow as well as by PCR, because NPM1 is one of the markers that you can track with PCR. And if it is low level, less than 2%, then you would just simply monitor him. If it is higher, you would consider a transplant.
Okay, thanks for that, Shilpa. So I think that would be a schema where most of us would treat in a similar manner. And this is sort of the sort of guidelines, what people would suggest how you would treat. So so which are the molecular abnormalities that one would track by PCR? So they recommend it's either the NPM1 or your core binding factor leukemia. These are the two main ones. that you would want to track by the quantitative PCR. And the methodology is typically by your quantitative PCR. So you're going to need to have a lab which is well standardized in using or who has a lot of samples doing those PCRs, because the methodology is different, especially your pipetting, the primers, the concentration, all those are important and can skew your results. So when do they say we should do it? So definitely one at diagnosis, you've got a baseline signature with you when you've sent your PCR or your quantitative. Then after 2 cycles, after 2 cycles, they say typically check your peripheral blood to do your quantitative PCR. All of us do flow cytometry. So you would be probably using both. You'll be doing the flow. Typical cutoff for your flow is about 0.1. That is what the international standard is. But all of our flows, we know in different labs, you can have different cutoffs, even going even lower. So you're going to look at the flow cytometry, and if available, you're going to do the PCR by NPM1 at diagnosis after 2 cycles. And then, as Shilpa said, end of treatment, after you finished your cycles, you're going to do again a bone marrow, and you're going to look at your PCR MRD. Now, they've said MRD more than 2%. So they're looking, it's called something like low-level MRD. So you have a 3 to 4 log reduction from diagnosis, or your MRD is about 2%, which is just above the detection threshold of the PCR assay. Now, the question is, when are you going to treat? At what level do you think you're going to treat more? And that is still open to debate. So right now, the data is that you do your end of treatment bone marrow, look at your MRD. All of us look at flow anyways. And then you follow up. So you need to do bone marrow every 3 months, or peripheral blood every 4 to 6 weeks to monitor the target. So that is the kind of follow-up that patients would need. She also rightly said that the NGS is going to be important, because the other molecular abnormalities as detected by the NGS will probably put the NPM1 mutated AML into an adverse risk cytogenetics patients where you would want to intervene sooner by a transplant. So doing the NGS in that 28-year-old is going to be quite important. So we move on. We've got a 51-year-old chartered accountant, hypertensive, who's otherwise well, newly diagnosed AML. Flow shows myeloid phenotype, leukemia phenotype with aberrant CD7. He's got a normal karyotype, but you've done an NGS. He's got STAC2 with a VAF of 13%, SRSF2 with VAF 9.1%. That's your NGS. We tend to get all of these molecular abnormalities. Same questions. Does he need more investigations? If so, why? How would you treat? Will you measure MRD? Rajesh, yeah, you can take it.
So can you again go back to the previous slide, Samir? So 51-year-old, apart from hypertension, really no other significant comorbidities. So we presume he has a good cardiac function, and we would certainly like to treat him with the intensive chemotherapy approach. So with regards to the baseline diagnostics, typical myeloid with flow pattern with aberrant CD7 expression. So we got something there which we can certainly latch on to and monitor. Normal karyotype. NGS STAC2 with a variable allele frequency of 13% and an SRSF2 of 9.1%. So we would certainly, in terms of any further investigations, I think we've pretty much done everything from a baseline workup point of view. Apart from, assessing for any comorbidities in terms of pulmonary function and cardiac function wise, with regards to assessing his fitness for intensive chemotherapy. So presuming everything will be okay, I think we'll go ahead with intensive treatment with like DA3 plus 7. And in terms of will you measure MRD? Well, looking at the ELN guidelines, I think we certainly can monitor his MRD on the flow because we've got a leukemia-associated abnormal immunophenotype. I've been traditionally doing a marrow at the end of induction after cycle 1 and certainly doing morphological assessment. And then for those who could afford, we have been doing MRD on that. But looking at the ELN, I guess you could wait until you do 2 cycles of chemotherapy before you actually do the MRD. So most of, I think our practice will probably sway towards not routinely going for an MRD straight after the first induction cycle, but probably waiting until after the second cycle, because I think quite a few might still actually have a high MRD after the first cycle, and we might be swayed towards intensifying our treatment, maybe without actually the need for it, based on what the ELN actually suggests. So, well, in terms of what method I would choose for NGS, I mean, what method I would choose for MRD monitoring. The advantages of using flow here is that it is relatively easily accessible. I mean, we can easily get the samples across, if not in your own place, I mean, to the nearest center, with a very quick turnaround time. And most of the labs have actually got, I mean, pretty good at doing a flow-based MRD as of now. So I think you can potentially get a very reliable result on the flow. When it comes to NGS, I think it is still work in progress. So the difficulty is that most places are not actually geared up to do it, and it is still in its infancy. Standardization is difficult. And with the amount of mutations that one is able to pick up, I mean, there is always going to be background noise. So what would you pick up as the important ones and ignore the ones in the background? I think we're still probably a few years away from going with NGS as your routine MRD monitoring methodology as of now.
Okay, thanks, Rajesh. So I think that's sort of standard what most of us would do. The STAC2 and the SRSF2, I think they come under an adverse prognostic risk. So one could think of transplant as well after discussions with the patient. So
Just
what?
one little interruption, me only.
Oh,
I was just asking, why would you like omit a routine PCR molecular panel and do just NGS?
so in our practice, at least we do cytogenetics, we do the standard FISH,
Yes.
and then we do NGS. I think that is what we all tend to do.
Yes.
It all tends to depend upon how many, what the financial status is and things like that.
No,
But-
because in this particular case,
Yeah,
there
so
was no
in this
fish.
particular case,
Yeah.
I'll tell these are all real patients. So I'll just discuss this. So if you look at the recommended ELN AML panels, okay, so NPN1, we all know we want to do core binding factors. We discussed that. So these are the two that we would do by the PCR. Now, what about other fusions? So what about the KMT2A? So that has got a lot of partners. So they have actually said not specifically recommended to monitor that because it's difficult to trace all of that. The concept is the same as before, but actually having those transcripts, standardizing them and monitoring it can be problematic. What about signaling pathway genes like your FLT3, KIT, and RAS? Again, possibly, because these are signaling pathways. They've recommended that you can check it by PCR, but that would not be the only thing that you would check. You would check other things like that. For example, you check your flow cytometry and check your PCR as well, because these are subclones, and the subclones can disappear and they may not actually inform you significantly, even if they are negative. What about the DTA gene? So these are the DNM3A, TET2, and SXL1. Again, they've said they have specifically recommended against monitoring those because these can be found as age-related clonal hematopoiesis, and they should actually be excluded from consideration. Then you've got your hereditary predisposition genes like your SEPA and your DDX41, ETV6, GATA2. Typically, you need to exclude them if their VAF is more than 50%. So these are considerations that I think one should take into account when we do our NGS initially and we see the VAF. Now, coming to your question, since it's high risk, there is a question of monitoring these mutations by NGS. Okay, so there is data to show that you can actually monitor these patients with NGS looking at the STAC2 and SRSF2, which will then inform you whether you want to go ahead with further transplant, although it's indicated in adverse risks. But especially those who don't want to transplant, you can actually monitor by NGS. Now, the cutoff for NGS for the mutations has been put at 0.1% VAF, but you can go even lower because NGS we know can go up to 10⁻⁻⁶. And now there is data to say that if the lower the MRD on NGS, the longer and better is the overall survival and disease-free survival. So that is one tool that you could use in your patients, typically in high-risk patients who don't want a transplant. You want to monitor them to sort of inform them to say that how they're doing. And this is what I'm trying to say by which clone we need to monitor. So this is a hematopoietic stem cell. This is a leukemia initiating cell, and these are the subclones. So all your signaling pathways, your FLT3, RAS are all these subclones. These subclones can disappear, and what we need to monitor are these leukemia initiating cycle clones. The similar things with here, your DTA, which is your DNMT3A, TET2, and SXL1, are slightly upstream than the leukemia initiating cell. So monitoring these is not going to help us too much because this can be clonal hematopoiesis. These are the molecular abnormalities that we need to target. I think I've just got 2 minutes more. I'm going to go on to a last case, which is probably going to be this one. Yeah. So the last one's a 71-year-old retired teacher investigated for bicytopenia. Bone marrow shows 12% blasts. Flow is consistent with AML. Normal karyotype, MDS FISH is negative, NPM1 mutated, FLT3 negative, NGS not done, 71-year-old, and same questions again.
So since he's 71-year-old, so already elderly. So in this patient, we will what I will do, any more investigation in GS specifically, I won't go. Can I go back to the questions? 1 second. No more further investigation for him. For treatment, I will select I will select an hypomethylating agent. Regarding venetoclax, we add in my practice, depending on 2 factors, availability and how the patient is tolerating. Then I continue. Third is, since it is, I think, NPM positive, the monitoring is same as per what Shilpa ma'am has told, that is end of therapy. And preferably, since he is elderly, I will choose peripheral blood, not to put the patient on repeated bone marrows. And lastly, since ASA and vein protocol is an indefinite therapy, sir. So I would continue the therapy even if there is a achievement of a MRD with PCR based and follow up in his OPD. Thanks.
Thanks for that. I think all of us would do the same in our practice. But as we spoke about NPM1 mutation and analysis, this data has been done in patients when they receive intensive chemotherapy. There is very little data in patients when we use less intensive therapy. So there was a recent article. This is NPM1 MRD by PCR who received venetoclax-based therapy for NPM1. So the same protocol, they've used ven plus either low-dose Aracian hypomethylating agents. They've achieved CR, CRI, and they've assessed the PCR in the bone marrow after 4 cycles. They've done this after each cycle. So the blue one is basically your MRD negative. And you can see that as they're going to cycle 4, after 4 cycles, 47% are MRD negative. After 6 cycles, 50%. So almost you can say about 80% of the patients in the cohort were MRD negative. And they then followed them up. And you can see that after 4 cycles, the survival is significantly improved, 84% versus 46%. 22 out of the 70 patients electively stopped the treatment after 8 cycles. And their 2-year treatment-free survival is 88%. So this is one thing to show that you could actually consider stopping. In MRD, it's always difficult to say when to stop. That's the problem. But here in this data, it's small data, but at least it shows the proof of concept that one could actually stop in the elderlies where we know toxicities can be higher. Cytopenias due to venetoclax can be higher, infections can be higher. So in that particular cohort, you could think that you could stop treatment after that. So with that, I'll thank my panelists for engaging discussion. Thank you.
Right. Thank you, sir. Right. Thank you, Samir. Any questions from the audience? No, nothing. So you've done a fine job. Thank you very much.
Thanks,
And
Nitin.
also thank you to all the panelists for doing this. Thank you.
Thank you, all the panelists. Thank you, the moderator. Thank you, chairpersons, for your valuable time and presence. This is to inform that there are academic sessions going on simultaneously in Hall B as well. If you want, you may attend that as well. Moving on to our next session, which is again a panel discussion on using MRD to optimize treatment in pediatric ALL. For this session, may I request the presence of our chairpersons on the stage, please? Dr. Girish Balikai, consultant hematologist, hemato-oncologist, SDM Medical College and Hospital, Dharwad, Karnataka. Welcome, sir. Our other chairperson, Dr. Manthan Katrotia, consultant hemato-oncologist, Apollo Cancer Center, Ahmedabad. Welcome, sir. We have our moderator, Dr. Ranjit Kumar CS, and the panelists. May I also request you on stage, Dr. Rajat Bhattacharya. Sir. Okay. Dr. Abhishek Kumar, Dr. Shantanu Sen, Dr. Niharendu Ghara. May I request the chairpersons to kindly introduce the panelist and the moderator to the audience? Thank
Very
you.
good morning. Thank you. Thank you for the opportunity. And I would like to introduce moderator Dr. Ranjit from Hyderabad, who is going to discuss about the MRD in optimizing treatment in pediatric ALL. And we have a panel members. Dr. Rajat is my good friend. I think he's going to come now. And he's from Kolkata. And Dr. Abhishek Kumar, he's in Kidwai Institute in Bangalore in pediatric oncology. Dr. Niharendra Ghara, senior consultant in the Department of Pediatric Hematology Oncology in TMC, Kolkata. And Dr. Shantanu Sen, he's a consultant pediatric oncology and BMT in Kokalabin Hospital in Mumbai. Please, Dr. Ranjit, start. Thank you.
Yeah. Good morning, chairpersons, for the kind introduction. So, next couple of minutes, we'll discuss the using the MRD to optimize the treatment in the pediatric ALL. So it's a brief introduction. We all know that MRD is basically defined as the detection of the minute level of the leukemic clone, which probably like we could not able to identifiable through the conventional cytomorphology. We all know that bone marrow morphological assessment has a cutoff of around like 5% or like 1 in 100. We can actually use the terminology like minimal residual disease and measurable residual disease. And as of now, probably in India, we are using everybody like very familiar with the flow cytometry based MRD. And so in a pediatric ALL, we can actually have a cutoff of less than 0.01 to call it as a MRD negativity. So this, I think last speaker also has similar kind of slide. So the principles and prognostic significance of MRD based upon the different methodologies. And we'll go to the panel discussion proper. The first question would be, what would be the ideal sampling for the MRD testing? Is it a bone marrow or peripheral blood? Any of the panel member can take the question. What would be the ideal sample for the MRD testing?
As it stands, the MRD monitoring is still based on the bone marrow assessment. Yes, it would be ideal to go to a peripheral blood assessment, but it's known that the MRD levels picked up on, particularly for B-cell ALLs, the MRD levels are almost 1 to 2 logs. The difference is almost 1 to 2 logs between the peripheral blood and the bone marrow. So till we have got other methodologies to pick this up, it will stay with the bone marrow.
So I think that's the right thing what we do. Bone marrow is going to be an ideal sampling. There is always a 1 to 2 lakhs lesser in the peripheral blood compared to that of the bone marrow. So ideal recommended sampling is the bone marrow. That to the first 2 to 5 ml of the sampling is recommended. And these are the various cooperative clinical trials. If you can see, like all the clinical trials, they have used the bone marrow as a preferable sample for the MRD testing. And so we all know the different techniques and sensitivity. Already this has been discussed in the last lecture also. So we can see like morphologically, we know like 1 in 100 or like up to 5% we can able to discuss, we can able to detect by the conventional cytomorphology, whereas the flow cytometry 1 in 10,000, and whereas qPCR, I know 1 in 1 lakh cells we can able to detect. So the technique is like the more advanced the technique, the lesser the means like disease we can able to detect. So these are the like different techniques and sensitivity in the ALL MRD. And what are the ideal time points for the MRD testing in the pediatric ALL? What would be the ideal? When shall we do? Is there any like typical timing when we should do the testing for?
So it kind of depends upon what protocol that you're using to treat the patient. But your basic and the most important one that you want to find out is to check whether you have got your patient to remission by the end of day 28 or day 30. So that's your time point on which all your subsequent treatment decisions would be based on. And at that point of time, if you have achieved MRD negativity, then you know that you're on the right track and you can continue on the same treatment. Now, you can do an earlier assessment of MRD depending on the protocol, sometime around day 15, day 21. And you can use that to actually de-escalate your treatment. So if you have your patient who's entered into MRD negativity very early, so that kind of teases out a subgroup of patients who probably would have a much better outcome. And you may not need to treat them very, very aggressively. So you can, if your protocol allows you, you can use MRD at that time point to say that these are the patients that I can hopefully de-escalate, because that's what we are all trying to do. That we know pediatric OPD has excellent outcomes. Now, how can we maintain that outcomes while reducing our toxicity? If you have achieved your MRD negativity by day 30, then ideally, and this is something that I also practice, I would kind of repeat it again at the end of delayed intensification or BFM consolidation, depending on which protocol used, to ensure that your patient stays in remission. And I do one more by the time that we start our maintenance, but that's kind of depending on which protocol and practices.
Yeah, I think everybody does same thing, because as of now, we don't have a specific consensus, like fixed time points where we can do. It all depends upon what kind of protocol which we are going to use. I have similar question again to Dr. Santanu. We all use probably for the escalation of therapy. Is there a data for the de-escalation of therapy based upon the MRD?
That's a very good question. And that's the kind of answers that we are looking at with the current clinical trial. And certainly, I think as we learn to use MRD more and possibly using more finer refinements, that's what we should look at. But at the moment, as far as I am aware of my colleagues in India, I don't think any of us are de-escalating depending upon MRD. Rajat?
Well, I think all the clinical trials will answer the question. All I can tell you, or my previous hospital, the Singapore MASPOR protocol in the standard risk group, but they did it with the ddPCR. And it was anthracycline free, and we still had a 96% event-free survival on the group. So yes, it will happen in future, but at the moment, I think you have to be very careful.
I think,
follow the protocol, I think.
Yes. So probably I think we all use only the for escalating the.
Sorry, I just have one other comment. The other thing we need to kind of like and this is all of us practicing in India are very aware that we cannot directly extrapolate results of international trials to our patients. Our patients are different in terms of the biology of the disease.
Yeah.
Our patients are different in the terms of the germs that they all are exposed to. So I think all of us are a little bit worried about de-escalating treatment too early, because having a relapse in a patient is a disaster for the entire team. And I think we would be comfortable saying that let's give just that little bit of treatment, get that patient into good enough remission, and take him out, rather than doing it too de-escalating too early.
Yeah. At this point of time, probably MRD we are using for the escalating therapy if there is a MRD persistent positivity, not for the de-escalation.
May I just make a couple of comments? It's not. It's just addition to what has been said. Completely agreed that you cannot go beyond what protocol you are facing. You cannot just translate something that is from one protocol and take it to the other
Yes.
protocol. I think I get this question very often. So when we are talking about MRD, it's one is the technique and also the time point that we are talking about. When we are looking at the MRDs, the so-called MRD early, so that means that marrow was completely full with disease. When we are talking about ALL, you are doing MRD at day 15. So at that time, whatever is left, you hardly have got any regenerating cells because your MRD calculation is based on what your denominator is. You cannot equate that MRD to the MRD that you are doing at the end of induction, whether you're doing at day 28 to 35, where you have got your regenerating cells coming up. And whether you are doing it literally at that time or you are actually allowing it another week before you do it, because people have done that, that you will get a very big difference. And in terms of how often you do it, most of the protocols would possibly say end of induction, end of consolidation. But if they keep on, I mean, if you are having that positive, obviously you might need to change your protocol or modify considering transplant. In that case, possible idea would be to keep on tracking that end of every other phase of treatment that you are going through.
Yeah, that's why MRD based upon the flow cytometry, you need a lot of expertise because at the end of the induction, because the regenerating marrow will have a lot of confusion. So impact of MRD at the end of the induction in the pediatric ALL. So can we say like the child is having a MRD negative, he is not going to relapse? So I think this is actually like a curve. We can see like those patients who are actually like MRD negative, they have an event-free survival, overall survival is almost nearly like 85 to 90% in the at least standard risk group. Whereas MRD positive group are having around like 50% of the event-free survival. So that's what like we can see based upon the trials. Yeah.
Can I quantify that
Yes,
with
yes,
a
yes.
caveat?
Yeah.
All of us who are in transplants, we know the data is there that if you're negative, you have a very good outcome.
Yeah.
But unfortunately, that is not an absolute. And we all have patients coming to us who have achieved MRD negativity on day 28, day 30, and then unfortunately has relapsed again after that. So that's a bugbear that we all have faced throughout. So it certainly teases out your good risk population that will do well and you'll carry them on with the same treatment. I think MRD is very good to tease out which are the high risk patients and treat them aggressively. But we cannot say absolutely that if you're negative, that patient will never relapse.
Yeah. So probably at this point of time, still we are in the learning phase of the PCR versus like flow cytometry. Probably like PCR data on the long-term follow probably will tell us like whether we can actually like what would be the real scenario. So can MRD guide us for the treatment? I think this is we have been discussed already. So this is one of the UKLL 2003 randomized trial data. You can see like the standard risk or intermediate risk group where the children has achieved the MRD of 0.01% or higher. So they have actually recommended for the augmentation of therapy to the regimen C. And based on that, we can see that those children who received the augmented therapy has a better event-free survival, as well as the cumulative incidence of the relapse was less. And so probably like at both in the UKLL as well as the BFM trials, in the both standard risk and intermediate risk group, if they are having a persistent MRD positivity at the end of the induction, they recommend the augmentation of therapy to the protocol C or high risk group. So again, like UCAL 2011 protocol also suggests that if there is a persistent positivity of the MRD at the end of the day 29 of induction, they recommend the augmentation of therapy to the protocol C or high risk group. And so what is the role of MRD in the pre-transplant and post-transplant in the pediatric ALL? Is there any like data or like is there any like experience pre-transplant MRD and post-transplant MRD? What is our role? Like, do we have any data?
Well, any MRD before transplant is bad. Risk of relapse is very high. So we should try and very hard to go to that thing. Yeah, that curve. Yeah, that achieve MRD negativity. Whether you go do it by flow or deeper remission is better.
Yeah.
And any MRD post-transplant, I think immediately, yeah, you let the GVL or effect come in. But before, after both are bad. Probably pre-transplant, we should not take a patient with BLL or with ALL to transplant if they have MRD. Try hard to achieve remission. I think everybody does that. Yeah.
Yeah, the pre-transplant MRD is extremely important to take the children into the transplant. If there is a negative MRD, probably like it is a better event-free survival and cumulative incidence of relapse is less. So we'll see some of the data. So we all know that pre-transplant MRD, lesser the pre-transplant MRD, outcomes like cumulative incidence of relapse are going to be less. And what would be the ideal method of detection again in the pre-transplant MRD? Is it NGS or like flow cytometry again? So we know that we are actually very comfortable when we are actually doing the conventional chemotherapy. We all know that flow cytometry is a quite bit standardized in our country. PCR is still probably in the learning phase. So we still is not known that what kind of MRD we can actually use for technique wise. And we cannot probably like interchangeable the techniques based upon the protocol probably we need to use. So any comments on this?
I'll slightly disagree on that first point. In a sense, I think we had this comment in the last session as well. I think MRD is very operated dependent, flow cytometry.
Yeah.
Taking it as an easy technique, I think that's possibly the biggest mistake that we can think of. Every single lab is offering MRDs.
Yes.
Not sure.
Yeah.
Not
So that's
sure.
why we need actually expertise.
Yeah. So to say that actually we have achieved MRD, this thing, I know for my lab, I work in a pretty good center, Tata Medical Center. I know how long it has taken to get to a respectable level in terms of establishing MRD. It's not an easy technique. Similarly, trying to interchange between the NGS, obviously that has become the standard practice abroad, and all the studies that you are looking at presently are looking at the NGS based or IGTR based MRDs. Other than the difference in techniques, flow cytometry has its own pros, and similarly the NGS or an IGTR, because the IGTR will only pick up the clones that you had picked up earlier.
Yes.
Yeah. Because you are tracking that particular clone. Flow cytometry, you've done in good hands, can also pick up the clones which are coming up later.
Yeah.
So it cannot be literally be used one or the other, but whatever a particular lab is comfortable with, or a particular the transplant unit is comfortable with, is possibly what we would go with.
Yeah.
I completely agree with you. I mean, we all get very used to saying that let's do it by flow. When you choose a lab where you do it, you need to see how many of these MRD samples they are processing day in, day out. As Navindu said, it's extremely operator dependent. So you see the flow graph, and depending where you draw it, you decide what your MRD percentage is. And very easily it can differ by a log of 1. So labs which does it regularly, on the go, all the time, processing a large number of samples, would give you a better result. And ideally, there is a lot of interoperator variability depending upon who does it.
Yeah.
And looking at the same flow chart, 2 different operators can give you 2 different results. So that's a problem with MRD by flow. And I think if we go for something that's a bit better, deeper resolution, less operator dependent, we can actually take our treatment decisions bit easily.
Yeah, that's why like the flow has a lot of observable variability. That's one of the important factor which we need to consider. This study is basically to tell us like what could be the better method of using the MRD pre-transplant. If we are actually using the NGS based MRD, the 2 years relapse probability is almost nil if there is a pre-transplant MRD is negative based upon the NGS. So that's the main data for this. And again, if you see like various actual like trials, the PCR based techniques, which was actually in the 1990s and the latest trials, they have used various methodology, but qPCR is not, at least not in our country, like where there is like European countries where quite oftenly they are using the qPCR as a standard technique. And what is actually pre and post transplant minimal residual disease prediction about the outcomes? So probably this is a good data. They have actually studied 119 children. Those children's and the pre-transplant MRD, if it is negative, they had almost like a probability of the survival almost like a 73%, versus like the relapse by the pre-transplant MRD who is positive, cumulative incidence relapse is also less. So this is the data. And what is like the with respect to the CR status, like CR1 and CR2, the pre-transplant MRD and outcomes. So what is like the data tells us? Can anyone take this one? Pre-transplant MRD with respect to CR1 has a better result and CR2 has a better result. Of course, we all know that ultimately MRD should be negative pre-transplant. But if you see like CR1 patients, those children who are having MRD negativity and also like MRD slight positivity, that means like less than 0.01, they almost are having a similar kind of survival. Whereas in the CR2, any kind of MRD positivity has a very high probability of the relapse if there is MRD positivity. So what we need to learn in this graph is CR2, at least MRD negativity is must for us to take for the transplant, because any MRD positivity having a very high chances of relapse. So what the
Can I just make a comment
please.
on the last statement?
Yeah.
I think we are having a lot of conversation about so-called the MRD negativity.
Yeah.
Now, the MRD negativity, when we are saying that MRD negativity, we need to be very careful about what level we are talking about.
Yes.
If you look at the agglomerate data that Connie or Cornelia Eckart did for BFM and UK data together. So initially, because BFM had said 10 to the power minus 3 and then equal. So for them, 10 to the power minus 3 and lower would have been negative. UK stuck to, or UKLL stuck to 10 to the power minus 4. Looking at the data, when they put it together, 10 to the power minus 4 and lower would possibly will do better.
Yeah.
So basically deeper remission and this.
True.
For this question between CR1 and CR2, I'll just take this example as to what has it taken the patient to be taken to that CR. So if Dr. Shantanu has taken a flight to come to the same destination, where possibly Rajat and I have possibly taken a cab and come here, the ease of coming to one place. So the surrogacy that MRD is not the only point. It's only one of the very important factors that decides what the ultimate results could be, but it's not the only not the only one.
Yeah.
So how long it has taken, how you have achieved that becomes very important. CR1 would obviously be different to CR2, where you have given a lot more drugs to come to that state.
Yeah. So this is probably like old data, because before what immunotherapy came actually. So we are actually going to see that part also, like post MRD, like if there is a negativity post transplant, so what is outcomes we will see. And so we all know that Forum trial, probably the largest trial which has evaluated the TBI versus chemotherapy-based transplant in the pediatric ALL. So in this trial, surprisingly, we all actually talk about the MRD and its importance in the pre-transplant area. But this trial has shown that MRD level did not show any event-free survival, surprisingly, in the Forum trial. Probably like when we go through like the deeper understanding of the trial, so they have included most of the favorable MRD profile group in this trial. Probably that could be the reason, like in the Forum trial, MRD was not shown any like benefit in the EFS. And so the post-transplant MRD, like if you see post-transplant MRD be associated with the higher chances of the treatment failure or cumulative incidence of the relapse. And so post-transplant MRD early versus later means, like, for example, in the first 100 days and then like after the 100 days, if there is a like a negativity or positivity, what it has the impact on the outcomes. So anyone can take up this. So
post HSCT, if MRD is coming positive late, then it will be worse, better prognosis as compared to early MRD positivity.
Okay, so this trial has shown that, for example, like the first trimester and second trimester means like less than 100 days and more than 100 days. Those children who are having a first 100 days of MRD negativity, and they are continue to have the negativity, they have a better probability of the survival than those children if actually they are having a negative and then they are actually becoming positive at the end of the 3 months. Their cumulative incidence of relapse is very high. So that means we need to actually monitor very like the tight manner frequently the MRD testing and post transplant also, so that like we can actually pick up these children early. Even at the MRD level we can probably augment the therapy, or another thing is probably we can actually like de-escalate the immunosuppression so that we can actually like induce the GVHD, or we can do the DLI. So that's what we can do. So this is again the similar data. So we know that the higher post-transplant MRD levels associated with the higher risk of the relapse, and the later the MRD positivity, the higher the risk of the relapse. Hence, we actually need very close monitoring of these kids, even the post-transplant. So this is one of the very good trial, more precisely evaluating the peri-transplant MRD levels and risk modeling. If you see the data, they have actually like divided the children into the 4 groups: undetectable MRD and detectable MRD, both based upon the PCR as well as the flow cytometry, and also high MRD positivity, very high MRD positivity. If you see the 2 years of cumulative incidence of relapse, those children who are having the MRD negativity has the least chances of recurrence compared to the very high positive. So therefore, like we need actually pre-transplant MRD negativity is extremely important to take up these children for the transplant. Is the prognostic value of the pre-transplant MRD higher or lower than the post-transplant MRD? Does it has any influence on the outcomes? Ajit sir, can you take up this?
I'm actually not sure. It depends on how you're transplanting and what GVHD prophylaxis and how you're using the GVL effect to your benefit, whether you're doing a haplo or a sibling. And so there are many variables. So any MRD I would take as a problem. And I'm not entirely sure whether this data will change, whether it's early or late. And so I think it's a very variable things we're showing, and we don't know the answer if at the current moment.
I'm trying to read the graph, but I mean, basically the way I look at it, your most important decision before you take a patient to transplant is check what the patient status is pre-transplant. So if your patient is in good, complete remission with MRD negative, then that's the best patient you can take. Now that always doesn't happen, and sometimes we have to take a patient for a transplant who's still MRD positive. So those obviously would be the patients that you're really worried, because those are the ones that will give you trouble going on. But please tell me what your
Actually,
slides
like
show.
this, so this data actually like just give an idea for us, like those children who are having MRD positive low pre-transplant, MRD high and very high MRD. If ultimately they achieve the MRD negative post-transplant, they have a good prognosis. That's what this data tells us. So ultimately, like the negative pre-transplant MRD and post-transplant negative MRD has a lower risk of the relapse. That's only like a conclusion from the data. And again, if you see this data, those children who are having the very high MRD, if they have a post-transplant MRD negativity, they have a very least chances of cumulative incidence of relapse. And again, like the effect of the acute GVHD, if you see, those children who are having the acute GVHD, they will have a less risk of recurrence. This we all know that.
Can I make a brief
Yes,
comment?
yes,
I
yes.
mean, we always kind of think that if you have GVHD, then there's less risk
Less,
of relapse.
yeah.
But unfortunately, that is not an absolute
Yes.
situation. We all have patients who have had GVHD, some of them pretty bad,
Yes.
and then also they can relapse. So the mechanisms can be slightly different. And well, if you have GVHD, it makes us feel good. And what many of us do, at least with AML patients, that you've done a transplant, and I would actually do a bone marrow at day 45 and day 90 and check what's happening to the marrow itself if the patient's MRD negative. At both those time points, if I find no evidence of GVHD, then we actually do a cycle of DLI at day plus 90 to actually precipitate and get some GVL effect in that. So it goes together, but also not always.
Yeah. So that's why like probably MRD alone, probably we cannot take into the consideration. There are a lot of factors will come, but this data will just give an idea for us, like those children who are having GVHD probably have a better, less relapse risk. So what is the relation between the chimerism and MRD? So all the children who are having a 100% chimerism, that means like they will not relapse. It's again like it's a difficult question. Probably like I think chimerism we should not use as alone. Probably we need also do the MRD combination. If somebody is having a MRD negativity, become actually coming the molecularly positive disease, probably we need to augment the therapy or we have to do the preemptive DLI. And this is one of the data with the 163 children. Those children who are having increased mixed chimerism without like they have actually augmented the therapy in this trial. Those children who had the increased mixed chimerism at some point of time, and those children received the additional immunotherapy, they did better than those children who did not receive. So this is the actual like a data. Those children who are having MRD positivity along with the increasing chimerism, when they have done the additional immunotherapy, they have a event-free survival was better than without therapy. Without therapy, almost like a dismal prognosis.
Can I just make a quick comment? I think this is my lecture in a couple of hours, so I'll tell you very briefly what I'm going to say in a couple of hours. Use both. So they are
yes.
complementary to each other, and you should monitor both. And either if your MRD becomes positive or if your chimerism is dropping, both of those are harbingers of a disease that's possibly coming back and you got to react to it.
Yes, both the things has to be done, not the alone. So with that, I would like to conclude that MRD will help us both pre-transplant as well as post-transplant to guide us. We know the pre-transplant, we know based upon all the cooperative clinical trials, we can probably augment the therapy at this point of time. We still are not comfortable with the de-escalation of therapy. Whereas in the post-transplant, if the MRD is positive, probably like we can actually consider the early withdrawal of the immunosuppression so that we will induce the GVHD. That will probably help for the GVL effect. And we can follow the preemptive DLI. And as we saw the data, like we can actually, those children who are having MRD positivity, we can probably consider the additional immunotherapy so that like they will relapse is less. And of course, probably we can consider the latest one, CAR T cell therapy. So with that, I would like to thank all the panelists and chairpersons for giving us this opportunity.
Any questions from the audience? So thank you all the panelists. That was a very nice discussion, and we have addressed almost all the questions which we face regarding MRD in our practice. I would like to ask one question. If the ALL is high risk from baseline, like KMT2A mutation or BCR-ABL positive or PH, like in that, would the strategy of monitoring MRD change, or if that patients are having early MRD negativity, would that high risk mutations we can get away without,
Stay as high risk. So even if they are MRD negative, that does not de-escalate. So if you have any of those, I mean, if BCR-ABL positivity, they will remain high risk.
Yes, sir. So strategy for MRD, sir, do you change in your practice? You monitor it more frequently, or?
Depends what you plan to do. I mean, if you're following a protocol where it says that you would, I mean, BCR-ABL is a difficult one because right now we know that if you are BCR-ABL positive, you put the patient on imatinib and they actually no longer need to consider going for a transplant. So that group is different. So if I discount that, and if you have any other markers that says it's a high risk, he remains on high risk, he'll remain on a high risk protocol regime. They'll be on a regimen C if you're treating on UCAL or a BFM on a higher, whichever. And you follow the your time points where you do MRD. And at any point, if it's MRD positive, you got to take him for a transplant. If your protocol says that there are certain factors which automatically makes a patient eligible for a transplant, then you don't actually look at MRD. You know that this is a patient I need to take for a transplant, you take for a transplant.
I think just a comment. I think the problem of doing MRDs at whatever time people feel that is very easy. It's not. A lot of people do MRDs in the middle of maintenance and then want to interpret that. You cannot interpret that because what cells you are looking at there is almost impossible, and we do not know what happens there. So it becomes very difficult to extrapolate those results unless somebody has relapsed.
So then I would like to conclude the session. Thank you, everyone.
Thank you, panelists. Thank you, moderator. Thank you, chairpersons, for your valuable time and input. Next up is another panel discussion on using MRD to optimize treatment in adult ALL, for which I would request the chairpersons on stage, Dr. Shubhronil Baul, Associate Professor, Department of Hematology, NRS Medical College and Hospital. Welcome, sir. Professor AIG, Professor and Head, Department of Clinical Hematology, North Okalapa General Hospital, Myanmar. Welcome, ma'am. We have our moderator, Dr. Sitaram. May I request you on stage, please? There has been a slight change in the list of panelists where Dr. Rajesh Malik and Dr. Rajat Bajaj has kindly agreed to fill in. And I would also like to call Dr. Debmalya Bhattacharya on stage, please.
Hello. So, Dr. Sitaram from Bangalore, sir. Good morning. And I think without wasting any further minute, I request you to start the panel.
Good morning, everyone. Thank you, Jyotik, for inviting me to moderate this session. I think the previous speaker has kind of spoken a lot about ALL, so there'll be a lot of repetition. Probably we all know that majority of our adult patients achieve remission induction, but a significant proportion of them will relapse. So we all know that MRD has become a powerful tool to predict the relapse. It helps us to maximize the efficacy of the treatment and also minimize the adverse effects. Thing about ALL is it's probably almost all patients of ALL, we can use some methodology to check MRD. And sometimes, probably not in our setting, a combination of method needs to be used. So I'll probably skip this question because it's been quite repetitive. It's basically about techniques and methods of MRD, which we have been through quite a lot. I'll probably just comment on this technique. There's, apart from the currently known techniques of flow cytometry, PCR, and NGS, there's some emerging methods like uroclonality NGS capture, which integrates chromosomal translocations and TCR and IgG rearrangements with copy number variation. And there's also some research in spectral flow cytometry, which uses multiple markers. So I'll probably start off with this question. So with the currently available methods in ALL, what are the advantages and the limitations of each method? And how do you use that in your clinical practice? Dr. Rajat, Ranjit.
Thank you. We have had a couple of discussions on this in the last hour or so. So the most commonly employed method is still flow cytometry, multi-flow panel flow cytometry. The advantages is that it is fairly easily available. But as some of the speakers during the previous discussion mentioned, it has to be done the right way. So they need to be people who know what they're doing with large volumes of samples going through the lab, so that they know the ins and outs of the technologies they're employing and the interpretation of it. So easy, yes. Cheaper, quickly done, quick turnaround times, and that is the advantage of the flow cytometry based testing. With regards to the PCR-based testing, yes, you can probably look at a much deeper MRD. With your flow, you can probably go up to 10 to the times -4. With PCR-based, you can potentially get it up to like 10 to the times -5 and possibly 10 to the times -6. But it is not very easily accessible, and standardization, at least as of now, is an issue. So, but I think going forwards, I mean, I know we've been doing PCRs for BCR-ABL for quite some time, and that certainly can still be employed in the pH positive ALLs. Whereas for the others, when you're looking at either the T cell gene rearrangements or immunoglobulin rearrangements, standardization certainly seems to be an issue. And when it comes to the NGS, we heard, I think, Dr. Jabbar yesterday say they're increasingly moving towards NGS as the way of monitoring their ALLs. I guess it'll be the case with us as well in some time, but right now, the cost of it, lack of easy accessibility, standardization definitely seem to be issues. And yeah, as you mentioned over there, clonosec is the one that's been FDA approved. Every now and then you come across patients having their sample sent across to the US. Significant delays in terms of getting the result, significant expense involved. And some of these patients actually need quick decisions. And if you're taking 30 days or 25 days to turn around the result, quite a lot of time has elapsed in the meantime. So I think in terms of making quick decisions, it is a bit difficult.
Thank you. You have any comments to?
Just to add to that, with the NGS, another problem that comes up is that sometimes we don't have the baseline NGS.
Yeah.
So that becomes a problem in interpreting MRD. We don't know how to interpret those.
Yeah, as rightly pointed out, this slide just gives a comprehensive overview of various techniques with the flow, the PCR with where you look for IgG and TCR rearrangement. And with NGS, we cover about 90 to 95% of patients, whereas where you look for gene fusions like BCR, ABL, and they're only about 40 to 50% of patients. It's applicable only in 40 to 50% of patients. Advantage with that is that you have standardized primers, so it can be applicable at all points. Clearly, a major limitation is the standardization, which is very difficult, especially in our country. And also, I'm not sure how many of us use PCR. Again, you know, that's a very difficult technique. So, and as I understand it, even for your immunoglobulin and TCR gene rearrangement, by PCR, you will have to have, initially, you have to design a primer and then follow it up. But the problem with that is sometimes there can be clone switch, and you may miss that in subsequent samples. However, NGS is clone unbiased, so it probably is the future. Okay. So this again has been discussed. I think I probably will just. I was hoping a lot of trainees would be here, so I thought it would be more tuned towards trainees, but it looks just us. So what are the practical consideration one needs to take into account while sending for MRD? If one of you could just comment with particular respect to source, quality of sample, and the limit of detection.
So yeah, the preferred source obviously would be a bone marrow sample. And apart from the source, it's very important, like we were discussing in the last panel, the timing of doing the MRD. It cannot be randomly taken. The samples for MRD, they have to be at a specific time point. Preferred sample is obviously a bone marrow sample, first pull, and yeah, we need to minimize the pre-analyticals and standardize kind of whatever methodologies we have, and we've seen the limits of each test, like the flow cytometry. It detects up to 10 raised to -4, PCR 10 -5, and NGS even more deeper.
Any comments you want to add, Rajit? Oh. So yeah, as you rightly said, the bone marrow is a preferred sample. However, if you're doing a regular monitoring, it might be very tricky. Not many of our patients will agree for repeated bone marrow. Certainly in T-cell ALL, we could consider peripheral blood monitoring, where it is found that the MRD is roughly equivalent, possibly because it arises from the thymus. Whereas BALL, we have to stick to the bone marrow. However, in future, if we have availability of high throughput sequencing, then maybe we could replace the bone marrow with the peripheral blood. As you said, it always has to be a first full sample. Preferably get a senior person a senior trainee to do the sample. Okay. Right. Slightly switching to more clinical scenario. Either of the panelists can take the question. Who have a newly diagnosed BALL patient? When do you actually what time point do you check your MRD? And how frequently do you monitor it? What's the rationale for that? And how do you tailor your therapy based on your MRD results?
So in my practice, for newly diagnosed precursor ALL, provided there are no markers which can be monitored by PCR, like a BCR-ABL, CRLF2, etc., I do MRD at the end of induction. That is usually 4 weeks. That MRD is by flow cytometry. If the patient is MRD negative, he continues to get the protocol. If the patient is MRD positive at the end of induction, then I go and escalate the treatment. And the other time point where I do it is before the beginning of maintenance.
So what protocol do you use in your?
So we use pediatric inspired protocols. It's mostly BFM.
BFM. Anything you want to add?
Yeah, I mean, I usually follow the UK ALL protocols.
Yeah.
I mean, almost up to the age of 27, 28, I still go with the pediatric protocols. Whereas beyond that, I'm currently following the UK ALL 14 protocol. And for the over 60s, the UK ALL 60 plus protocol. So BALL's day 29 at the end of induction and MRD, and then the treatment plan subsequently. So very rarely, I mean, if the MRD at the end of induction is not quite there, I might be tempted to continue with the consolidation and repeating the MRD at the end of it. But for most people who have achieved MRD negative at the end of induction, I don't routinely do one at the end of consolidation.
Okay. Would you consider, say, for example, an alternative PCR-based technique, or is that something which you have used along with complementary to the flow or?
No, honestly, I mean, so for what I've done here is completely flow-based only. I mean, I've had a dialogue with the pathologists. I mean, we send samples to AMPATH in Hyderabad. That's our sister concern. And it's mainly because they haven't got a standard set of assessments yet. So I think we're still going with flow-based. And one of the problems I have is you're following the UK protocols and they're talking about MRD 0.005, and we usually here get numbers of like 0.01, 0.1. So how do you translate that and make a decision basing on that? Sometimes I find it very difficult.
We have similar problems because we've been trained similarly. Only thing is that I've started using the pediatric UK protocol up to 35 now. I'm just pushing the boundaries. I know it's about 25. So this is
Shantanu, I think, has a point.
Sorry. So this is one field where the adults can follow the pediatricians rather than the other way around. That has been forever. So we know that outcomes with pediatric protocols are better. And the latest ALL protocol that's going to come out is called All Together now. And it's every European country together with the Brits and the Americans getting together to treat every ALL patient, start from 1 year to 45 years. So it's truly all together with one single protocol.
Wonderful.
Yeah, we're trying to push the boundaries up and up. So in the adults. There's this probably everybody knows, there's a meta-analysis of 16 studies comprising more than 2,000 patients, which showed MRD negativity as a better disease-free survival compared to MRD positivity. As regards to how frequently we have to do MRD, a German study clearly demonstrated that the 90% of patients relapsed within 4 months of MRD become positive, which is why I think most of us will use 3-monthly monitoring. When there was a survey done by various European hospitals practicing MRD, they do probably about 4 or 5 times a year, which roughly equates to about every 3 monthly or so. Next question is, if you have a high-risk ALL, would that change your strategy in monitoring, or would you still continue with the same strategy as what you just described?
Probably continue with the same strategy, but we'll have a low threshold towards proceeding with an allogeneic stem cell transplant. But if the MRD is positive, we know that deepening the MRD prior to going for a transplant really influences the results post-transplant. So it gives us a chance to maybe look at alternative means of deepening the MRD with something like blinatumomab or inotuzumab. Not something I can do in my practice. Apart from, sounds very appealing and very nice, but certainly not where I practice. I think is not something that I tend to do or get to do.
I think similar as my practice, we don't get a lot of chance to use blin and inotuzumab. But the time point of assessment for pH positive ALLs is at the end of 3 months. So that's where I keep a watch. So I assess these patients at the end of 3 months by an RQ-PCR.
Do any of you actually look for pH like ALL? Because I've tried to, do you look for pH like ALL fusions, gene mutation? Is that something you do routinely? This is a question to audience as well, if somebody does it.
So yeah, for patients who we think can afford that, we definitely try and do a pH like ALL. Yeah.
Okay. Because we're trying to find a center where they can do pH positive. Is that something you would do, Dr. Shantanu, pH like ALL? Yeah. Okay, thank you. So just a bit of a slide about pH positive ALL. About 25% of our ALL patients are pH positive. Luckily, we have cheaper TKIs now, so which we can use, which is definitely improved the outcomes. Unlike CML, where we have a standardized way of monitoring, P190 is not well standardized, so that's a challenge. IgG rearrangement is a good thing to look into, but again, most of us don't have access to that technology or technique. Again, there's the concordance between the two techniques is only about 67%. So currently the recommendation is both needs to be monitored. Clearly it's a challenge in our setting. Right now, switching the gears to the transplant patients, when do you check MRD in post-transplant patient, and when would you intervene if they are MRD positive?
So day 60 is when I usually do an MRD for ALL patients post-transplant. If they're MRD negative, just keep them on observation. I don't do an MRD after that. And for patients who are MRD positive, ideally, I would like to give them something more like, say, blinatumomab maintenance post-transplant. But obviously, that is not a choice that we always have. And so day 60 is when I do an MRD post-transplant.
Yeah. Anything you would want to add upon?
I don't do allos at the moment, so
Okay.
yeah.
Okay. So I'll probably just skip this question. Just go to current recommendations. So when we look for MRD, baseline specific immunotype or clonotype needs to be identified. And then you have to follow them after induction, consolidation, and delayed intensification based on which protocol you used. The recommendation during maintenance therapies every 3 to 6 months, you check for MRD. It can be a challenge in our setting. For transplant patients, you do pre-transplant. Most of us do pre-transplant MRD assessment. Followed by day 45 is the recommendation. I think most of us would do either day 60 or day 90. And then they say that you have to check at least a month or two for 1 year post-transplant, which I certainly don't do at the moment. And if we have access to peripheral NGS, then we can possibly use peripheral blood, which would make our life easier. This slide again just highlights the recommendation which I've just alluded to. So if they are standard risk patients, you just check MRD after induction, and then they proceed to consolidation, and then you do MRD negativity, and then they proceed to maintenance therapy, after which you do it every 3 or 4 months. However, if they become MRD positive, or if they have any of these high risk features, you consider if they're eligible for transplant. If MRD negative, take them to transplant. If MRD positive, if you have access to blinatumomab or rituximab, you can give them that and try and get them to MRD negativity, and then they take them to transplant. If they are transplant ineligible, again, you do MRD. If they're negative, you continue to consolidation and maintenance with probably 3 monthly monitoring. And if they're MRD positive, then you can try and give blin followed by maintenance therapy. So I think this has been spoken to before. What cautions should one exercise while interpreting MRD, especially with novel therapies? And if you would want to take the question.
I guess with access to new therapies and with significantly better outcomes with the use of these therapies with regards to deepening the MRD, I think the onus to do more frequent MRD monitoring becomes the case, because you have access to these drugs, and then you can potentially deepen the MRD response pre-transplant or potentially post-transplant with a view to considering maintenance therapies. So I think the frequency of monitoring and the use of these novel therapies, I think they go hand in hand. So you'll be monitoring the MRD much more frequently with these newer therapies.
Any other cautions that you would? Yeah, I mean.
If you're using a CD19, either a CAR or you are using Glina, your 1019 strategy is not going to work. So then you have to devise a strategy how you're going to do the MRD monitoring, because you're still dependent on flow cytometry MRD monitoring. So the normal flow cytometric methodology will not work. So somebody has to be very used to looking at this, as we were alluding to earlier, because we are not using IGTR or NGS.
So it's also quite important to inform our laboratory colleagues about the kind of treatment the patient is on, because otherwise, we might end up getting a false report. I think with this, I'll conclude. MRD is a fundamental component of risk-directed therapy. It's, as we all know, it's independent prognostic factors. With regards to ALL, we are fortunate that we got it covers almost all categories and subcategories of ALL. In future, we probably will do more and more of escalation or de-escalation of therapy based on ALL. Novel agents are playing an increasing role, but whether the MRD negativity translates to the MRD negativity of the chemotherapy agents, we assume it is so, but I think we still have to wait for the long-term data. The development of HTS may help us further. As I said earlier, the standardization is still lacking among various centers. Just not, I mean, even in the West, it's lacking. So, it's even more in our country. The other thing is that certainly we have to, ALL is a heterogeneous disease. So there's genetic factors which we have to take into account. So it may be that just 10 to the power of -4 for one subtype of ALL may not be the same for the other one. So we may have to take that into consideration before interpreting the reports. So it's very important, as we discussed, to have the knowledge of methods and limitations so that we can interpret the results better. The future is getting complicated for hematologists, I'm sure, but the results are getting brighter and brighter. So thank you.
Thank you very much for a very lively discussion. And now the floor is open for questions, discussion, and comments.
Thank you for that excellent talk and panel discussion. I actually have a question. Sorry if it sounds like a repetition, but for Ph positive ALLs with P190 transcript, my question was what are the time points where you're monitoring for the response and what methodology are you using? Because it's hard to find a lab with a standardized P190 monitoring. So.
As regards to, we use flow, but we have a very good molecular lab. So they do P190. I understand it's not standardized. As regards to time point, we just do in parallel with the flow. So the same time points as what I'm using for the flow. I don't think there's a different recommendation. The recommendation is possibly the same for both, whether using PCR or flow. At the moment, we are using both. Just for the BCR-ABL one, because our lab is good for that, but not for the other gene fusions.
With respect to the response levels, is it the same as what we follow in CML? Is that what you're following?
Yes.
Okay, thank you.
Any more questions or comment? If there is no more questions or comments, I would like to thank the moderator and the panelists for a very informative discussion. And thank you all.
Thank
and
you.
now
Thank you.
Thank you. Thank you.
That was a very engaging and interactive session we had. Thank you, panelists. Thank you, moderator. Thank you, chairpersons, for your valuable time. Next up is another panel discussion on MRD in CLL, ready for clinics, for which I would request the chairpersons on the stage, please. Dr. Ishwar Singh, Consultant and HOD of Department of Hematology, Purvanchal Cancer Hospital, Jhapa, Nepal. Our other chairperson, Dr. Gaurav Karia. Dr. Karia. Okay, we do not have him here. We have the panelist, Dr. Partho P. Gupta, Dr. Jashasvi Chakraborty, Dr. Dibyendu De, Dr. Kaushik Pal, and Dr. Gunjan Prasad. I welcome you all to the stage. May I request the chairperson to kindly introduce the panelists to the audience, and our moderator is Dr. Nitin Sood.
Okay, do you want to?
Thank you. Today we have the discussion that we are having is CLL in clinics, MRD in CLL in clinics. Is it? Are we ready right now or not? And then I would like to the moderator to begin the session today.
Okay. Thank you, Dr. Singh. I've got a few panel members, and we've got like 15 minutes, so we'll rush it. Dr. Tulpule and Dr. Ram and Dr. Anjit have done a great job doing the acute leukemia MRD, and now we're ready for the chronic leukemias. I mean, CLL in MRD is an entirely different discussion because we've got various drugs. So as we all know, we're moving away from chemoimmunotherapy in CML. We used to do FCR, BR. But now we've got the targeted agents, and the targeted agents have their own good things and bad things and specialities and the way they affect the MRD. So the first in-class BTK inhibitor was ibrutinib, and then subsequently we got acalabrutinib and zanubrutinib. We don't have access to zanubrutinib, but we've got access to both ibrutinib and acalabrutinib. And although the proprietary versions are pretty expensive, we've got generics of both, although ibrutinib generic is about to go, I'm hearing. And so the other drug that is very important for CLL is the BCL2 inhibitor, venetoclax. And venetoclax, AbbVie is getting very soon in India, so we'll have access to it. So we need to learn about how it affects MRD. But despite all these improvements, we don't see a cure. There are fixed duration therapies which might offer a cure in the future, and that's why we need to learn about MRD. Despite all this, most patients need multiple lines of therapy, and sequencing is also important. So the other thing that we need to learn is sequencing. I mean, we know from this conference that MRD is used in several hematological malignancies now, and it's got a demonstrable prognostic value, at least in CLL. It's got value in many other diseases, the prototype being CML, but the CLL use is evolving, and that's what we've got to learn. So I've got only one case, and through this case, we're just going to go through MRD at various time points to see and how we all deal with MRD. I think most of us probably would be doing some CLL MRD. So this is a 73-year-old man whose comorbidities include hypertension and hyperlipidemia. He was investigated for knee replacement, as it happens so often, and when he was worked up, lymphocytosis was found. We did a flow, CLL was confirmed. But he didn't need treatment at that point, so he was watch and wait for about 6 years. But this visit, he says he's got fatigue. His bite count has gone up to 113,000. There is some bone marrow failure, and now he meets the IWS-CLL criteria to treat. So these are the treatment options at the moment that we've got, and some of them are standard recommendations. So if I just can I start with Dr. Gunjan? What treatment in your center would you offer such a patient? 73-year-old with some comorbidities, some bone marrow failure, not a huge amount, not too much bulk of the disease at the moment. Would you offer continuous BTK inhibitor therapy, or do you want to do fixed dose therapies? I don't think your mic is working.
Hello?
Yeah,
Yes, I
yeah.
would go with BTK.
So ibrutinib or acalabrutinib, do you have access to both?
We have access to
Yeah.
both, sir.
Yeah. So yeah, that is what we would do. If he doesn't have too many comorbidities, could just got hypertension, so we've got to keep an eye on that. So we'll do ibrutinib. I don't think many people would do fixed dose Ven or Ven-R combination at the moment, unless any of the panel members do it at the moment. No? Do you?
We generally prefer to go for ibrutinib, but we provide the options to the patients also. But generally, at this age group, we generally try to go for the ibrutinib.
Right. So this fellow has read up on MRD, and he's a very knowledgeable fellow. And he asks you, should I do MRD? Should we do MRD at this date? And would you encourage MRD testing?
The caveat is here that when we give ibrutinib or acalabrutinib, this is a continuous treatment, and hardly these patients ever achieve MRD negativity.
Yeah.
So doing an MRD testings will be difficult in these situations. But if the patient goes for the fixed duration chemotherapy, immunotherapy based regimens, then probably we want to have a cure, and then in these situations, then we'll try to go for MRD testing.
Yeah. So potentially, if I can ask Dr. Gupta, if you were to do MRD, when would you do
I
it?
just want to put forward something like
sure.
giving isolated ibrutinib, as Dr. Dibendra has already told, that MRD will not be useful. But if you look at Helios trial, if you look at Illuminate trials, they have combined ibrutinib with either rituximab or obinutuzumab or ibrutinib plus FCR. So
Yeah.
in those combined regime, MRD detection is useful.
Yeah, well, that's a very important point. Very good point. So FCR, we know that some patients on FCR would get MRD negativity, so chemoimmunotherapy. And there was this time point when we were considering that you do 3 FCRs and then MRD, and if it's negative, we'll leave it at that. But as Dr. Day rightly pointed out, BTK inhibitors, hardly 4-5% patients would go into MRD negativity. So its value there is very limited. So yeah, that's true. You would not recommend MRD testing for somebody on BTK inhibitors. So, I mean, what kind of MRD do you do if you were hypothetically to do MRD? Or would you do a flow-based MRD or NGS or PCR? Yeah. Yeah, I think it's working now.
Mostly, basically, flow cytometry based MRT is going on. But if you consider the sensitivity and depth, in that case, NGS should be the ideal.
Yeah.
Ideally, NGS should be done, but in most of the centers, flow cytometry is going on.
Yeah, yeah. No, we also do flow cytometry, which gives us like 1 in 10,000 cells, so 0.01.
Yes. But sensitivity and depth, no doubt, NGS is much better.
No, I agree. I agree. Is your standard doing IWCLL criteria? Yeah, it's working.
So IWCLL criteria of MRD negativity that tells us as less than 1 in 10,000 cells that is considered as MRD negative. So even with flow cytometry, that type of sensitivity can be given. But obviously, if we go to the NGS, we can get a deeper response.
Yeah, yeah. So PCR and NGS, as I think in the previous Dr. Ram mentioned, -5 is PCR and -6. So 1 in a million cells, we can go up to 1 in a million nucleated cells, which is very, very deep testing. Whether that really improves outcomes and whether that can be achievable is a different question. But those are the methods to do it. I don't know if any of your centers are clued up to do NGS MRD. We don't do it at the moment. At the moment, we only do flow-based MRDs, and that too, you have to really convince your pathologist to do it. So, right. So, useful in which situations? I think we've discussed that anyway. Right. So he decides on acalabrutinib monotherapy, and we've decided that he doesn't want to do sort of fixed dose therapy. He takes it for 2 years, and now he wants to stop. He's in a clinical remission. Will MRD help now? Do you want to?
I think although BTK inhibitor gives with BTK inhibitor there is lesser chance of getting MRD negativity.
Yeah.
But after 2 years of therapy, ideally I think we should go for MRD testing by flow to see what is the level of response that this patient. And if the patient achieves a MRD negativity, then it can be assumed that the response is reasonable and good, and at this moment can be stopped safely.
One thing I want to mention that there is, if we stop either ibrutinib or acalabrutinib, though MRD is negative, in case of CLL, there is high possibility of relapse.
Yeah, no, I agree. So in which case, I think I wouldn't recommend stopping or doing MRD.
And I think it should be continued.
At least in a BTK inhibitor, yeah. So we decided to continue. We convinced him to continue, and he did continue. But as it happens so often, despite taking the medicine, he did relapse on acalabrutinib monotherapy. So I mean, we've had BTK inhibitors for several years now, and most of our patients are relapsing now, or some of our patients that was started earlier were relapsing now. Despite MRD negativity, the outcome with, lack of MRD negativity, the outcome with BTK inhibitors is pretty good. And that we've all experienced firsthand now. So MRD is not something that really tells us about prognosis anyway, especially in the BTK inhibitor setting. But if he's now relapsed after 5 years, what kind of treatment would you offer him? Should I start from this side, Dr. Gunjan? I've listed the various options. Go on. Which one would you prefer?
So first of all, we need to see that whether this patient needs treatment or not, because relapse of a CLL doesn't mandate the patient to take any kind of therapy. We have to see the criteria. Yes, if the patient is going to take or is a candidate for therapy, the options are vein rituximab, vein obinutuzumab, and vein monotherapy. There has been MRD-based studies on all these groups of drugs with isolated vein plus R, vein plus Gazyva. So it has been shown that most of the patients, the deepest MRD response has been there with vein plus Gazyva. So if option is there, if the finance permits, I will be going for vein plus obinutuzumab.
Yeah. Okay. Okay. So, I mean, basically, those are the options. Venetoclax is not available. Go on. Sorry.
Yes, I think one thing I want to know that at baseline, at initial, what treatment that patient received?
Oh, no, this is the same.
Oh, only
patient. Same
ibrutinib.
patient
So
who was on-
rituximab not received.
Sorry?
Rituximab not received.
No, rituximab. Not.
Okay, in that case, I think we should proceed for either ibrutinib rituximab or venetoclax rituximab combination. I will go for.
Okay. Okay.
And I think other things we should consider, this patient is now 5 years older from
Yeah.
the starting point.
Yeah.
So the comorbidities and all these things has to be considered
Yeah. No, I agree.
before
I agree.
selecting therapy. Because he is now 77, 78 years old.
78 with hypertension.
So that is very important before deciding therapy.
Yeah, no, I agree. I mean, plus MRD negativity is not the end goal in such patients anyway, because he's 78. I don't know if MRD negativity is something that we want to do in such a patient at the cost of toxicity that we get. So, sorry, you wanted to say something?
Yes, and another one thing I want to mention that duration of venetoclax. Though United States guidelines or United States data shows that more prolonged duration of venetoclax, but in more Indian scenario, in my experience, I have seen that Indians generally do not tolerate venetoclax full dose.
Yeah.
And it is very difficult to give 7 days or to beyond 14 days. It is extremely difficult one. Because
are you
possibility of cytopenia is very high. Indians generally do not tolerate high dose of venetoclax.
Yeah. Are you saying AML or you're saying CLL? I think you're saying AML, right? Because AML, it's aza-ven, it's very difficult to give, but when rituxi is still okay. Yeah, because I mean, you can use azoles as potentiating agents, but plus to reduce the cost of it. But in CLL, whenever I have used it, I don't think cytopenias have been such a big problem. AML, I agree, is a big problem. So anyway, we carry on. So when Ritux, when obinutuzumab are fixed dose therapies, and when monotherapy obviously is an ongoing therapy. So he asks about MRD again a year after being on venetoclax. So should MRD be performed now? Dr. Gunjan, can we start with you?
Sir, I think MRD should be done. Such drugs have toxicities also.
Yeah.
So
true.
de-escalation of treatment can be done if it's MRD negative.
Yeah. Okay. Go on, sorry, your view.
Agree with that.
Yeah. So yeah, I mean, I would do MRD too. But although MRD negativity is not the end goal in a 78-year-old with several toxicities of venetoclax, we should be careful, and we shouldn't really, overtreat such patients. So he actually decides on Venritux for 2 years, which is the standard relapse sort of protocol, 6 months of rituximab, venetoclax for 2 years. MRD at the end of therapy using a multicolored flow shows a clone of very small clone of 0.02%. Dr. Dave, would you stop therapy or would you continue? He's
So,
78, he's got
yeah.
comorbidities.
Obviously, at 78 years, we would try to de-escalate the therapy, but whatever the trial data showed that the time point when he have first achieves the MRD negativity, we should continue at least the similar durations of therapy after
Yeah.
MRD negativity, and then we can go for stopping the therapy.
Yeah,
That
well,
will give
that's-
us a persistence of MRD negativity.
Yeah.
But obviously, we need to discuss with the patients the goal or the expectations of the patients, whether we should try to go for that MRD negativity persistence.
Yeah.
That is the importance.
Yeah, no, that's a good point. So that's what FLAIR trial is doing. They're using the same amount as it took to get to MRD negativity, and then they stop. So that's their finite therapy. Although outside a clinical trial, the finite therapy is 1 year for ven obinutuzumab and 2 years for venetux. Did you want to say something?
Just want to add one thing. Even after parallelly with the MRD, we should do a physical examination and also sometimes radiological examination if any lymph nodes are persisting, because sometimes it might so happen that the MRD is very low or the MRD is negative, but still some lymph nodes are present. So it has been seen that MRD negative plus no lymph nodes versus MRD negative plus lymph nodes. The first group of patients do well and show a deeper response for a longer duration of time. So basically, CLL is a compartmentalized disease. So even if the the blood MRD is negative, the recommendation is go for a marrow MRD. So even if the marrow MRD is also negative, then also we cannot say that the patient is completely cured of the disease, because malignant cells might be compartmentalized to certain organ from where detection of MRD is next to impossible.
Correct. Like lymph nodes or spleen, you're right. So yeah, so the other question really to the panel is, would you do MRD from the peripheral blood or would you prefer a bone marrow sample? Anybody?
For initial testing, for response assessment, I think bone marrow MRD is sufficient, and it should be. Because sensitivity of bone marrow is much higher than peripheral blood. But while doing serial monitoring, it is very difficult to go for serial bone marrow MRD. In that case, I think we should proceed for peripheral blood MRDs for serial monitoring.
Now, so finally, I've just prepared some questions for the panel, and I think that is where we'll end. So we'll just go one by one, starting from Dr. Gunjan. Do you do MRD at your center or do you outsource it? And what kind of method do you follow? And
Sir, we generally outsource it.
Right.
And the method is like flow cytometry only, because it's quick and directly quantitative also.
yeah,
So
yeah.
I go.
And is it easy enough? Is the lab far away?
No, sir, I stay at a peripheral place, Siliguri.
Yeah.
So which is about 10 hours from Kolkata.
So you have to send it to another
Yeah.
city
We have
to
to
do it.
outsource
Yeah.
it.
That must be tough. Okay.
So, sir, are you asking about MRD in CLL only, or
Yeah, only in CLL. Yeah.
Okay, so.
But
Sir,
in general, I mean, this is
sir,
an
first
MRD.
of all, considering CLL, my population of CLL patients are very elderly patient. So in most of the patients, I am giving therapy for indefinite period with BTK inhibitors.
Okay.
So rarely I have patients with fixed dose therapy. So in CLL patients, I am not doing MRD.
Yeah.
But for other patients, I am doing flow-based MRD only. It's available in Metro City.
Yeah, so you have to send the sample to another city.
No,
Or
no.
the same city.
I'm staying in Kolkata, so it's done here.
Well, that's fine. And Dr. Day?
We have flow cytometry at our center. I am from Raipur, but we do not have till now the flow cytometry MRD testing for the CLL. So for CLL MRD testing, we send flow cytometry to the other labs, but the labs are there in our city also. There is also a lab, and also sometimes we send to other centers.
Okay. Okay.
Yes, definitely. I will go for flow cytometry based MRD. Even NG is basically not available in our setup.
Yeah. Yeah. And is the flow done at your center or do you have to send it somewhere else?
Yes, in other lab.
In another lab. Okay.
Coming to this question, it is MRD is still in clinical trial, not in clinical practice. And to tell you honestly, for my patient, I am not sending MRD for CLL patient. I am just doing clinical features, and based on routine blood tests, I decide upon treatment continuation or not.
No, I agree. I mean, to be honest, I don't think any of us will be sending MRD at the moment. This is just really BTK inhibitors are dominating our CLL treatment till we get venetoclax, when MRD will be useful.
And
which is-
still now in clinical practice, there is no clinical clear-cut guideline regarding
I agree.
doing this
Yeah,
MRD
absolutely.
testing.
Absolutely correct. Yeah, couldn't agree more. So although it's a powerful tool for response assessment and can be useful in certain situations like the FCR situation we said, and it has a potential to become a surrogate for progression-free survival because the trials take a long time to produce results. If we have a surrogate to shorten that time, that will really help to get the drugs quicker into clinical practice. And of course, we need to learn more about this and research more and find out where its exact role may be. As I said, undetectable MRD may not be the goal in all patients, especially the elderly ones with extensive comorbidities. Although the younger ones who would prefer a fixed dose treatment, at least upfront or maybe even relapse situations, it may be a very good goal. And of course, in elderly and people with comorbidities, there are other factors that take precedence, like their age, comorbidity, and stuff like that. So with that, I think that's all I have. Thank you very much to all my panel members. If I can just get them to stay for one final audience question. Yeah. I can hear you, don't worry.
With regards to your patient, I mean, say if you were in Takludin, I mean, asking about MRDs and so 73,
Yeah.
and if he was somebody who would prefer a fixed term treatment as opposed to a slightly indefinite or longer term treatment,
Yeah.
would something like bendamustine rituximab be an option?
In the past, yeah, but I think the problem is it's clearly inferior to the BTK inhibitor. So it's very difficult to justify that kind of treatment. And remember, bendamustine rituximab is not benign. We've seen like fungal infections, especially in CLL, where they've got immune, not great immunity anyway. Bendamustine rituximab, although it doesn't do cytopenias, it will immune compromise you. So I would really struggle to do that.
So my concerns mainly had been skin toxicity with bendamustine,
Right.
which didn't see very much in the UK, probably because they were all fair-skinned and it's not a very sunny country. But here, horrendous skin toxicity with bendamustine. I mean, but I think with regards to like when it comes to affordability and where you practice, maybe that may not be that much of a problem. But I think we're accessing stuff under the government schemes and stuff. So I still use BR as first line for many of my patients who keep getting treated on the government schemes and who want a finite amount of treatment.
Yeah.
But skin toxicity definitely a big problem with bendamustine.
Right. What kind of skin toxicity? Because
I come up with like papulonodular rashes and sometimes even 2-3 months after they've started bendamustine. And quite a few of them, when they've had biopsies done, there's eosinophilic folliculitis.
Right. Okay.
And they sometimes, I mean, have difficulty with the rash for 3, 4, 6 months after having completed bendamustine, actually.
Yeah. I mean, the reason why our view is skewed a little bit is because we compared bendamustine rituximab to FCR.
Yeah.
FCR was horrible. Bendamustine rituximab seemed okay.
Yeah.
But it's obviously now we've got a better option. So
and
it's hard to justify.
Acalabrutinib becoming generic and very easily available, though I think ibrutinib is now been taken off the shelves.
It's
the generic
disappearing off the market now.
Yeah, exactly.
Lots of patients are complaining.
Sure. Thank you.
Can I ask you a question?
Yeah, of course.
For some reason, you seem to attract a lot of CLL patients. We don't see that many. Unfortunately, in the few what we've seen, I tend to see a lot more fungal infections with BTK inhibitors.
Right.
Just wanted to check, is that been your experience? And how would you combine the BTK inhibitors with the antifungal, especially if you're using, say, venetoclax in combination with Venai regimen? what is your strategy, or what would you advise?
Yeah, to be honest, I haven't used the When I at the moment. But you're right, When I is coming big time, because we're going to have evidence for When I. We're going to use it as fixed dose combinations. Venritux, Venobinutuzumab, already there for relapse CLLs. We did this Calquence trial when acalabrutinib first came in. So it was like a phase 4 trial. So we had lots of people on trial, where they were getting free acalabrutinib, and there's about 3.5 years follow-up now. We enrolled about 7 or 8 patients in it. 5 are still continuing. I haven't seen a single fungal infection because they're so strictly monitored. I know, but even in general practice, ibrutinib, acalabrutinib, I haven't seen many fungal infections. So I guess, I mean, I think it's the cytopenias related to CLL. So if they present late and have lots of cytopenias, that's where the problem arises. But if you treat them early, then I haven't seen many fungal infections.
And you don't use antifungal prophylaxis?
No, we don't use prophylaxis. No.
Okay, thank you.
No.
Thank you, Doctor. Thank you, presenter, for the nice session. I have one question. Okay. In CLL, we see like lots of mutations like SGSV, JAP70, and TP53 deletion. And do we consider this mutation or MRD regarding intensification or like the de-escalation of treatment?
Yeah. So I think from a treatment choice point of view, these mutations. So the unmutated patients, the IGV, IGHV mutation, the unmutated are poor risk. The 17p are obviously poor risk, where we would prefer things like venetoclax to start off with, because the venetoclax was initially approved for this indication. But from a treatment stopping point of view, I think, I mean, they can be used for NGS based monitoring. But from a treatment stopping point of view, MRD is a better indicator. So even the high risk patients, if they're MRD negative, at the moment, if you're using fixed dose therapy, you can stop treatment if they're MRD negative.
So post allogenic transplant in CLL, when should the MRD be done?
Well, 6 months is the recommendation, but hardly any of us. I've never transplanted a CLL. I don't know if any of you have. It's just very difficult to transplant a CLL now.
What about CAR-T, sir?
Again,
CLL, sir, is there-
CAR-T was investigated for CLL. It's really not turned out to be a great option for CLL. I mean, we've got many other great options. So doing a CAR-T is very difficult. Although, again, the recommendation is 6 months. Very uncertain if MRD helps. But CAR-T is a one-off treatment anyway. So I think they've evaluated CAR-T followed by venetoclax. 6 months you evaluate, but the role is very uncertain. In fact, there's a very good review. I would encourage anybody interested to go through it in the ASH from last year's ASH, and that addresses all these questions about how transplant CAR-T, sort of how to use MRD, when to do MRD, that sort of thing. Okay, if that's all we have, thank you very much. I just want to thank all my panel members for doing an excellent job. Thank you.
Thank you, sir.
Thank you. That was an excellent discussion. Thank you, Chairperson. Thank you, respected panelists, and Dr. Sood for moderating the event. Now we would like to disperse for a quick tea break and make sure that we start the next session by 11:30 here. And I would also request you to take a look at the Verve Hall, where we have an exhibition and pharma stalls put up. So please enjoy. Thank you.
Yesterday.
ওই জায়গাটা দেখেছিস তো, পেছনটা জ্বলে যাচ্ছে পুরো। এই দেখ, দেখেছিস কত পরিষ্কার হয়ে গেল। একটু লাল হোক, কিন্তু ছবিটা তো পরিষ্কার হচ্ছে, কিন্তু পেছনটা আলো হলে পরেই ওটা বন্ধ করলে হবে না। এই জায়গাটায় পুরো লাইটটা, মুখে আমার আলো নেই, এই জায়গাটায় লাইট। এই যে সে দেখ, কালার হচ্ছে কিন্তু মুখ অন্ধকার হয়ে যাচ্ছে। মুখে লাইট বাড়ছে না তো, পেছনে লাইট বেরিয়ে যাচ্ছে তো। যা বলবি, তোদের মর্জি। জায়গায় অনেক লম্বা প্যাকেজ বাজেট ছিল পেছনে লাইট থাকবে যা হবে হবে ওই ইমিডিয়েট তাই তো বন্ধ করো আনা হয়ে যা হয়ে যা ওর কোনো প্রবলেম নেই এই এলি তুই কখন থেকে উঠছে ওরা হ্যাঁ হারিয়ে গেছিলাম এই ভাড়া দিতে দেখা যাবে আমি
Hello, morning once again, all the delegates and faculties. Welcome to the second day of MRDCON once again. We have gathered after a short tea break and would head to our next session, which is a talk on MRD after CAR T cell therapy, which will be chaired by Dr. Tushti Ganguly. May I request your presence on the stage, ma'am? Dr. Ganguly is Consultant Hemato-Oncology and BMT, Ruby General Hospital, Kolkata. Welcome, ma'am. Our speaker is Dr. Penny Tan. I would request Dr. Ganguly to kindly introduce Dr. Penny to the audience. Thank you. Dr. Penny,
Hello.
may I request your presence on the stage, please?
Please welcome Dr. Penny Tan, who is General Manager of Cell Therapy and a Global Lead at Oxy Therapeutics in Malaysia. Over to you, ma'am. Thank you.
Thanks, Dr. Tusti. Thanks for the committee, and also thanks, Dr. Jodip, for the invitation. So allow me to introduce myself. I'm Penny.
Okay. Yeah.
Thank you. Thanks, Dr. Tusti. Yeah. Allow me actually to introduce myself and also for the today's topic. Today, we would like to talking about the MRD of CAR T cell from a perspective from a scientist. So, allow me actually probably just to introduce myself and my background and my faculty and also disclosure. I'm Penny. I'm a General Manager Cell Therapy Global Lead and also Head of R&D and Scientists. from Oxy Therapeutic. I obtained my PhD pharmacology, major in biopharmaceutical. My project mainly dry cell and gene therapy, and also I have my completed my professional certificate of biological therapeutic from University of Oxford. And currently I have the collaboration and so research project with different faculty and also different university itself, like UMMC, University of Malaya Medical Center, for a few project, like for example, we're doing CRISPR-Cas, mainly drive for AMPL, and also versus the fish project. And we also have another CRISPR-Cas mediators, Cas19, Cas 12A, 13A, and also Cas9, three type of comparison of the protein base for the CRISPR project, mainly drive the rare type of the organ transplant. And also we have quite a number of the project ongoing, like bispecific mRNA lipid nanoparticle together with the PROMAC, and also working together with the University of Oxford, MRC, WIMM, and also the Medical Research Council from UK, and also a private hospital like Subang Jaya Medical Center, Sunway Medical Center. So this is my disclaimer. So today mainly my topic and everything is just based on my knowledge and also my sharing, and more on education purpose, not really considered as a official statement from the Oxy Therapeutic. So today my agenda will mainly touch on the early MRD status, predicted progression, PFS, and also the OS, and also the second we're sharing on immunogenicity of CAR T cell. We believe this is actually the hurdles in MRD negativity of CAR T cell, and monitoring of circulating CAR T cell and cytokine detection in post CAR T cell, and also a real case study sharing from Malaysia. So we always believe that the early MRD status after the CAR T cell infusion able actually to predict the PFS and also OS, because a lot of talking about the MRD, we know the MRD actually is a small cell that going to detected after the post-treatment tumor cell. And MRD help identify early at-risk patient prior to the progression, and able to provide a rationale for designing MRD-based risk-adaptive CAR T-cell clinical trial and also commercial setting. And talking about the monitoring, measuring the MRD, we know that actually using a traditional way or either morphology, it may not be able to detect it. But however, if you're using a high sensitivity kind of like the screening or high throughput, like for example, flow cytometry, NGS, all these things, or RPCR, actually all these can able actually to give a very good result or detectable on the MRD, which is able to help the clinician to predict even better for the outcome and prognosis. And we know that actually MRD positive, and by actually, if you able to predict well or having a result on the MRD status, you're able actually to help to play a very important role in the prognosis, evaluation, and also management of the patient. And of course, we know that talking about the MRD, sometimes even though like having a CAR T cell and all these things, it was still a great challenge for doctor, for the patient to achieve the MRD negative due to the tumor heterogeneity and off-target effect. So there is actually a common and novel MRD assessment method after the CAR T cell. So we can see from the time point, pre and post CAR T cell, you can collect either way using a bone marrow or either a peripheral blood, depends on the disease itself. Like ALL, we are still prefer to use the bone marrow sample collection for checking all the MRD. If like the lymphoma or multiple myeloma, you can use a peripheral blood, which is more promising, easy, and non-invasive sample to run the checking and also the screening. So after you collect the specimen, you can actually send for MRD detection via a different kind of the method. Here you can see that you have flow cytometry, a high throughput, like you can use just the cell, a fresh viability cell, you can able to run it. So it's quite simple step as versus some of that you will probably need more skill. Like for example, NGS, you need the DNA, you still need to run the DNA extraction. Then after that only can proceed to run the DNA using the panel. Like PCR, you have real-time qualitative PCR, you still need the RNA. Like other method like NGF, digital draw PCR, RNA sequencing, you will probably need a different kind of the sample type like RNA, DNA, cell, or either different type. So can see that on the right-hand side, the disease burden, right now that in our system only can able to check 10 power -4 to -6. So for those that actually below than that, you actually unable to detect the MRD or the truly negative MRD. So we believe that the association of the MRD status after the CAR T-cell treatment will actually drive the clinical outcome. So can see from this, just an example, sharing about this 4 clinical trial, can see that different type of the method that you've been using for MRD. Let's say, for example, FCM, which is flow cytometry, patient who achieve MRD negative, complete remission compared with those who do not respond were associated with better EFS and also the overall survival. Same goes to the another trial Yen on using the method of the flow cytometry. Positive MRD was associated with lower EFS and higher 1 year of cumulative incident of relapse. And from the third study, you can see that if you're using a qualitative PCR, the absence of complete MRD response was associated with an increased CIR as well. And also if the fourth result study using the NGS, you can actually in the outcome, you can see a similar predictive power for less relapse and better overall survival was shown from patient with a negative NGS MRD at 3 and 6 months. So we know that actually the MRD status can really play a very important role after the CAR T-cell treatment and also drive the clinical outcome. So, but however, we know that actually there is another hurdles that for us actually to achieve to bring the patient actually to achieve the MRD negative. One of that actually is the immunogenicity of CAR T-cell. The main reason that you can see that the 3 major components, we believe that actually the immunogenicity mainly drive due to the certain reason, like for example, the current existing market, they are using a murine type of the single change fragment or a non-human. So the non-human sequencing in the single change fragment will lead to the development of anti-CAR antibody, which is the body will treat it as a foreign subject and then it will attack it back. And also will sometimes will induce actually the autoimmune disease in that patient after the CAR T-cell infusion or limiting the repeat dose and therapeutic outcome. Can see from that, some of the patients, they want to go for the second infusion, but however, it have shown a rejection on that. You're unable actually to react and then you're unable actually to detect the expansion of the CAR T-cell in the body. And the T-cell immune response directed against the foreign subject in the CAR transgene limit the CAR T-cell persistence, impacting the clinical outcome as well. And of course, there is another topic talking about the allogenic. Allogenic actually got the 2 different way of allogenic. One is actually you're using a donor cell as a starting material to produce the CAR T-cell. But that is also considered a type of autologous, but however, using a donor. Another second type is you already actually homogenize it. You did the CRISPR-Cas or TALEN or box technology. You knock out and knock in the HLA, certain type of the gene that what we don't want to in order actually to reduce the graft versus host, a truly allogenic CAR T-cell, whereby it will have the chances that probably have the immune rejection like been shown actually in the bottom, poor persistent as well. So what is actually the strategy that you can overcome the immunogenicity related risk of the CAR T cell? You have the three major type. Of course, talking about humanized sometimes was still able to having the same issue of immunogenicity depends on how you design the humanized, because humanized, you probably will still have 3 to 7% of the non-human sequence inside there. For example, you're using goats, or you're using murine, or you're using rabbit. Yeah, so this is kind of the common type, like when we're talking about humanized, how we can mimic the humans single change fragment. Or another easier way is you go straight to the fully human single change fragment. Yeah, that is another way that you can really escape and bypass the having issue of immunogenicity. But we know that actually it's not that easy for us to use a fully human single change fragment because of sometimes it will have the stability issue, or sometimes it will have other issue for us actually to sit in actually in that manufacturing of the vector. The second is conditioning regime. This is very important as well. We know that the bridging therapy and the conditioning play a very important role for the patient before actually infuse the CAR T cell. Yeah, that is because how intensive it is, the conditioning is it really depends on the type of the patient, depends on the budget, depends on the patient's response towards, because for example, we do have the patient, they have probably allergy, they unable actually to go on with the fludarabine or cyclophosphamide, then there's no choice that they move on actually to the bendamustine. But certain patient that actually like those that CD19 CAR T cell patient, why not to go with the CD19 CAR T cell? Certain patient that you start with the bendamustine as a conditioning, it probably actually will suppress the result and then unable actually to go with the expansion and also the clonal expansion in the body after the infusion. That is also another issue that we will face in our clinical trial. And then another second is the elimination of endogenous lymphocyte. For example, that some of them, they will say that during the harvest, probably when you start out, the blast is already very high, and then you harvest it, probably you have a very high granulocyte, very high of neutrophil and other type of the things in a white blood cell, so that when we do the isolation PPMC, and also we move on to the selection of T cell, it will actually affect having a very high percentage of the T cell. So it will affect actually the final product as well in our formulation. So there is also type of the things that how we manage from the harvesting, come to the reaching, and also conditioning, and move on to the infusion. And of course, another way also can say is another third strategy that we can suggest is use the non-single fragments base of CAR T cell. For example, like now we are using a receptor base, or you can use the Liga based CAR T cell. Like for example, some of them, they go with EpCAM, go with EGFR type of the vector CAR. Yeah, but of course, right now it's still at the preliminary data and the preclinical data subject, which is we are unable actually to draw any conclusion to say that actually it is better versus the existing that what we are doing, like versus the lentiviral or AAV. And talking about moving on to the monitoring of post CAR T cell, we actually suggest that on the day one itself, we should actually, before and after infusion, we should actually draw out the bloods or either take out the certain sample. Then we move on and checking on running the circulating CAR T cell after the infusion. So that is actually just the diagram that suggestion that on the different kind of the day, the clinician or in-house hospital itself should run immunophenotyping on CAR T cell, T cell or B cell, and checking on the cytokine detection starting from the day 0. Because actually the cytokine detection, we will suggest that actually day 0, day 3, every 3 days that you should actually to start to run the detection, because it's very important and Sometimes patient just show a fever. That doesn't mean most of the time when we're having a fever means it's infection. It's part of that. But actually in-house can be run just interleukin 6, not necessarily must be run the whole entire cytokine detection. It just depends on what existing that the system that you have. So right now from my end as a perspective of scientists, I would like to share that certain method comparison for detecting and monitoring CAR T cell in clinical trial and commercial setting. So the method commonly used for detection of CAR expression can go 4 major types. Can see that from organism and also proteomic and transcriptomic or genomic. Yeah, because different kind of the level will giving you different result. At the genomic level, real-time quantitative PCR and digital PCR, it will able to help you actually all the clinician to measure the CAR vector copy number while integration site analysis determine the site of the insertions mutagenesis. This is quite important when we run a clinical trial. But probably in the commercial setting, I would say that genomic level may not be drive the major thing. So, however, like for example, in the clinical trial or either in the commercial, we will advise to go with the proteomic level detection of the using a direct evaluation CAR functionality so that you can check the CAR protein using the flow cytometry with the staining agent or luminize and or either immunoprecipitation with the using the staining agent and also the microscope with the fluorescence protein fusions. So at the transcriptome level, RNA sequence measure the CAR mRNA abundance. Well, all this is mainly on our, I would say that more on our production side and also applicable more on clinical trial. However, in the commercial setting, the transcriptome level may not be really depict the real situation of how it drives the MRD. But however, at our level, we can able to see very clear picture that how it go on with the present and subcellular localization of the CAR mRNA molecule. Yeah. So the tools for CAR detection at proteomic level, I would say that this is more practical for the commercial setting. So that they have different kind of the way you can go. First thing is you can use the easier way, just one step staining, and compatibility with the antibody panel, which is using a flow cytometry. But sometimes it really depends on how you want to use what type of the protein or reagent, and then the specification or either access to the academic lab. But sometimes it's quite hard that if let's say you always have to send for the external to run the checking on the CAR detection. So we will advise that actually probably will check on an easier way, which is antigen-based method for detection of CAR expression. You have 3 major types, either direct detection or the biotin, the streptavidin-based detection, or either indirect detection. So can see that there is 3 types of reagent that you can use, a fluorescence type label or either biotin label protein, or another one, you just tag fusion protein at the tail, then you can able actually to detect the CAR T cell after the infusion. So always you have a pro and cons, depends on the time consuming or not, or is a lot of lengthy process that you need to go through. And for me, I would like to suggest which is easier way to go with in-house to detect it. So first thing is we need to know that what kind of antibody to use. We need to know our player first to detect the circulating CAR T cell. So probably we just draw one example for CD19 first. You can see that the player 1 type, you can just go CAR, just detection on doing the antibody of CAR, CD19 CAR or anti-CD19 CAR. Yeah. Or another method type that, which is the red color on that, is a player B, which is you just go and detect the single change fragment from the FMC63 presented on the CAR and enable the cell to bind on the CD19 antigen. This is another way that if you're unable actually to get the CAR CD19 antibody, then you can go with this kind of method. And another third method you can go with, which is player C. you can just check on the CD19 antigen presented, which is the purple color, which is almost sit on the tumor cell that side. So we would actually detect it, but this is a different. It is not the part A. You can see that the player C is completely different with the concept of player A. Yeah. And the fourth type that we can use is recombinant CD19 antigen, such as those that purchased commercially. So this is the easier way. We call it conjugated. Yeah, it have unconjugated and conjugated type. So if you want to detect it, you can just buy the recombinant CD19 antigen conjugated. So that easy for you, just do a staining. Another type that which is player D, refer to the conjugated antibody. Yeah, I hope that not so confused on all these few players, because this is actually the approach, different kind of the approach if you would like to detect the circulating CAR T cell after the infusion. So there is a lot of method that you can use. First thing is key reagent is dye. Dyes refer to the fluorescence dye. It enable for the clinician or the scientists to detect the various methods, like you using immunocytochemistry, Western blot, or either a flow cytometry. But normally at our center, we're using a flow cytometry because we know that the majority of hospital, the easier way to go actually is still the flow cytometry. So different dye actually can have a different wavelength. So it really depends on what kind of flow that you have. The normal color that we have is red, blue, or a violet. Some of them, they don't have violet. You just go with blue or either a red, good enough, which is you can able to have FET-C, APC, PE. I think all this is good enough for you to detect and find the circulating CAR T cell. And the second type of the key reagent is biotin streptavidin. Streptavidin is not a dye. Yeah, it is actually, you can see from that chart, can see antibody, it bind with the streptavidin in order for you actually to detect at the system or the color on the flow cytometry. So the function of streptavidin is very straightforward and easy to use. If without you using a unconjugated, you need to stain 2 rounds. If the conjugated, you just stain 1 round. Yeah. So that is another method of biotin streptavidin, which is you can use a ELISA kit. You can use either a direct ELISA kit or either a signal amplification of direct ELISA kit, as what is shown here. So this method, it really depends, but for in-house, it's very easy to set up because you can just buy from BD, bioreagent, or the common one. They already have a standard for you actually to drive through it. So it's easy for all the hospital if you want to run it in your hospital, rather than you send to the external lab for you actually to check on the circulating CAR T cell. Another third key reagent that you can use is free antigen. So free antigen actually is to measure the fluorescence antibody that which is bind to the CAR T cell, or you can use another one, fluorescence antigen, which is bound by the CAR T cell. So the concept is very easy. Yeah. So today I just would like to recommend the simplest method that you can set up at your hospital itself to run every weekly and even though monthly for those at the patient after the CAR T cell infusion. Can see that when we start with the DPBS, then we just put it in our cryo valve, and then we mix it up with our PBMC, which is the blood that you've been collected from the patient, and at the ratios of 1/1. Then after that, you centrifuge it for 5 minutes at the temperature of 27 degrees Celsius. And then you discard the supernatant using a micropipette. Then after that, you can separate out to different kind of the tubing. Like for example, you want to go, certain things have to must, which is if today you determine you want to check on CD19, then you will be against the CD3. But today you also can do together the CD19, CD22 against the CD3. Can see that is the anchor up there, the different kind of the CAR antigen that you can be used. So this is the easier method that you can set up in your hospital. Then after that, then you add on the streptavidin as a staining method, and then you send for the flow cytometry and you run it. So you were able actually to see the result. So I would like to just share about how this result will come out. just at the hospital level. We actually work up together with the Sunway Medical Center in Malaysia and also Subang Jaya Medical Center, which is we help them to set up in their in-house lab so that they can monitor the patient anytime. That is one of the case, a real case from the patient A is one of the relapsed PMBL, very young guys, 24 years old. That time he was actually infused with the CD19 CAR T cell full domain 41BB. So we can see that we have separate out FIT-C and also APC. Okay, soon. So we monitor from day 0, day 7, day 16, day 28, can see that actually the result on the graph there showing the expansion up to the day 7. But on the day 16, day 28, you start to dropping because of contraction. So actually it's also giving a very important information talking about the MRD for the clinician that they can actually check due to any reason. Is that because of patient having any infection or any other reason? On the day 28, this patient actually admit in the ICU. So you can see that the contraction result showing on the day 28. And very, I would say that this graph is presented very good, is like you can show a coronal expansion on day 28 onwards up to day 23. Yeah, this patient actually after the discharge actually from the ICU, when we manage well his infection, and see that the T cell memory able to clone it. So it become a clonal expansion on the second line there. So this patient on the day 36 onwards, when we reach actually the point of 60% on our result, the CAR detection, the patient actually achieved the complete remission. So it's there whereby that actually from the clinician side, they will feel, I wouldn't say secure, but however, they can able to know that how this patient doing in vivo or in vivo, rather than everything we just based on the medical assessment. That is also, of course, I would say that medical assessment is very important, but however, you have another reference for you to check. Yeah, during that period of the time of post CAR T cell and before of a patient achieve the MRD negative. And we do check also the cytokine detection for this particular patient. We can see that on the day 7, day 10, the patient's interleukin 8, interleukin 6, and interleukin 10 actually is shoot out, but the most actually mainly driven by interleukin 8. Interleukin 8 actually is the pro-inflammatory marker, which is recruit the neutrophil to help out on the wound healing, help up on the angiogenesis. So that's whereby I would think that the cytokine detection also play a very equally important role when you compare with the circulating CAR T cell. And the second case that we would like to share is this is a patient that on CD30 CAR T cell is a Hodgkin lymphoma relapse patient. And the patient actually have a very weird kind of the T cell that when we harvest it, because we have been trying very hard to culture this patient's cell. But however, along the journey of culture, the cell keep dying. And we have no choice that we have a discussion with our clinician to see that what we can or shall we just abandon it. But however, this patient have been completely exhausted with what kind of the treatment. So whereby we go on a trial for this patient. So at the day 7, we straight go for infusion without waiting for the complete dose. It means that at the end, we only able to harvest at 4 million cell for infusion. Normally, we need 2 to 3 million cell per kg. Per kg means that, for example, the patient is 50 kg. We times, let's say, 2 means that we need 100 million cell. But we are unable actually to culture 100 million cell for this patient. We only can achieve is 4 million cell because the cell keep dying every day. So we go on at the day 7 because we know that this patient actually having an issue of T cell exhaustion. Surprisingly, when we infuse it, we can see on the day 7 and day 14, it expands so quickly actually in the patient's body. Can see the day 7, it expand 80%. And also the day 14 is 72%. It's a miracle actually to us because we initiate thought that it's way below of the dose and it will not going to work for this patient. But this patient actually, the lashes and also all that sign and symptom been dismissed, disappear. And my doctor is really, really happy and excited and share with me, Penny, we make a miracle for this patient. But it's just one case. We are unable actually to draw any conclusion until we have a bigger number. So whereby we want to say that sometimes if the cell having a T cell exhaustion doesn't mean that it can't go in for the infusion with the full dose. If the really, really low dose, you still can able to go for the infusion and you still can achieve actually the complete remission sometimes. Yeah, so that is just a sharing. Maybe just a little bit of suggestion for the future cell therapy that what kind of things that actually you can monitor for the patient after the CAR T cell. So thank you actually for today my sharing.
Thank you, Dr. Penny, for that wonderful and insightful lecture. And I would like to invite 1 or 2 questions if there are any. Okay, so I'll just ask you just one small thing is that since you've been monitoring this with flow cytometry very frequently.
Yeah.
Yeah, because we're doing it on day 3, day 7. So you will do it only on 1 or 2 markers or the entire markers?
Or right now in Malaysia, how we do it in our private hospital is majority of cytokine detection be very frequent every 3 days. But however, for the circulating CAR T cell, we go by 1 week. Day 7, day 14, then we straight go in every 1 month. Yeah, then later on, then after 3 months and 6 month patient already complete remission, we will move on to longer period, 1 year, 2 year, and also 3 years. Yeah.
Okay, thank you so much. Thank you, Dr. Penny.
Thank you.
Thank you, Dr. Penny, for the exceptional and insightful talk. For the next session, I would request our chairperson, Dr. Tushti Ganguly Madam, to be present with us. This is a panel discussion on MRD in lymphoma. Does it have a role? For this, I would like to call upon the stage the panelists, Dr. Shazia Gulshan, Dr. Ishwar Singh, Dr. Debranjani Chattopadhyay. I think she's on the way. She'll be joining us in another 5 minutes. This discussion will be moderated by Dr. Girish Balikai. I would request chairperson to kindly introduce the moderator and the panelists to the audience and handing over the session to you, ma'am. Welcome, everybody.
Welcome Dr. Girish Balikai, who is a consultant hemato-oncologist in SDM Medical College and Hospital, Karnataka. And also welcome Dr. Shazia Gulshan, who is consultant in hematology in Peerless Hospital, Kolkata. And Dr. Ishwar Singh, consultant and HOD Department of Hematology, Purvanchal Cancer Hospital in Nepal. And Dr. Debranjani is she's on.
Thank you, ma'am. Good afternoon. At the outset, I thank the organizing committee for such a wonderful, insightful the meeting. And since yesterday, all of you had really nice meetings with a lot of robust data and a lot of charts and everything. And today, this is about like with any kind of hematology malignancies, we have a question about what about lymphoma? I mean, I think compared to the AML, we have quite a good success in lymphomas, but still we are lagging behind, and sometimes we fail to detect some of the cases which whether we should have done something else or whether we should have upgraded the treatment. So here comes the MRD in lymphoma. I mean, then again, still the question is, does it have a role? We are in such an infancy stage now. So we have to ask, like, first thing is it necessary? Second thing is it possible? And how is the next question. Yeah. So I just go through the quick about introduction methods and try to go through the different various lymphomas. Obviously, the MRD in lymphoma in any hematological malignancies, especially with liquid malignancies, what we call it as, and it's an invaluable tool. Especially ALL has got a fantastic. We got a lot of protocols and a lot of guidelines about the in ALL, but about the lymphoma, we are still lagging behind. And as such, lymphoma is such a heterogeneous disease. We never know how this patient is going to do. I mean, although we have such a prognostic markers and monitoring is also there, but still we do lag behind. At the moment, we have current treatment response and surveillance is mainly we have a radiological tools like a CT, MRI scan, and obviously the PET scan. Sorry.
Yeah.
Oh,
May I ask her to come on stage?
Please welcome, ma'am. Please. Yes, please.
Okay. Please welcome Dr. Debranjani Chattopadhyay. She's a consultant in the Department of Clinical Hematology and Cellular Therapeutics in Tata Medical Center. Thank you. Please carry on.
Thank you, ma'am. So currently, whatever, we have a quite good diagnostic tool, but at the moment we have a limited option for the surveillance and detection of any kind of relapses and to see the deep response. We have a limited tools. So obviously we need to have some in say next in 28 minutes, something like that. We want to answer whether we need a MRD in lymphoma. Second thing is how we're going to do it. Okay, is it going to work? That's what we're going to ask. And obviously there are a lot of studies. Whenever the new drugs or new regimen comes in, there are people are doing the sensitivity test to kind of mainly basically to make sure that we are achieving a very good remission. Second thing is whether we can get the drug approval sooner and quicker. Okay, that helps. Otherwise, getting a overall survival and PFS, it takes long time, especially low-grade lymphomas. Is difficult unless 8-10 years time. So that's why the people are doing the MRD in a trial setting, and absolutely they're doing a fantastic job. So, but still the MRD negative patients and measured with the conventional methods, these patients will relapse. Okay. And obviously there lies a question about what about the newer and more sensitive. Achieving 10 to the power of -4, is it good enough, or 10 to the power of -6 is important? We're still in a kind of like nowhere. We don't know where we are now at the moment. So, but still there are things. I think I'll start with the panel about some few questions. I think the basic questions which we would like to know. How do you monitor your lymphoma patient? I think that's quite basic one, probably. Please, ma'am. Yes.
As overall with everyone, I do monitor my patients with PET CT scan,
PET
both
CT
interim
scans, isn't
and
it?
at
Like-
end of treatment.
Hmm.
That is conventional, which is going on with for everybody.
Absolutely. Yeah.
And
Yeah.
it remains to be seen how much, I mean, of course, in all the clinical trials, you see MRD as actually is benefiting, but how much we're still not coming to clinical practice.
Absolutely. I mean, even the ALL, because we see there's so much of robust data,
Exactly,
and probably we had this argument in the pediatric ALL, which is the kind of although CML is the kind of a top in the list, but still the ALL is the second one. But still they got a controversy how to do it, when to do it, how to interpret it, and whether it's useful in my patient or not. That's what it is. But still we are in infancy. But there's always a kind of a way to go. And obviously there is a difficulty in radiological settings. Okay. As you know, this Rattle studies and many studies have shown that in Hodgkin's lymphoma, PET 2 in the interim scan has shown a fantastic clinical guided thing. So what is your thoughts about other non-Hodgkin's lymphomas? Do you comment, please, ma'am?
So just like you pointed that in Hodgkin's, it really has a very good correlation between
Absolutely.
the disease burden and the PET-CT.
PET-CT, yes.
Now, in other lymphomas, the problem we usually face is in DLBCL.
Yes.
Many a times there is a discordance between the imaging and the tumor burden.
Yes.
We're not very sure whether when there is an uptake happening in the marrow,
Yes.
actually the marrow is being involved or not.
Yes.
And very often we find it difficult to do bilateral marrows for our patients.
Absolutely.
So it's not always reflective.
Mm.
But nonetheless, in most of our patients, we do a PET-CT only to guide the end of therapy. Although we do an interim PET in most of our patients, that is mostly to see if there is any disease progression,
Yes.
especially in our double hit lymphomas.
Yes.
And the end of the PET, if end of treatment PET, if it comes as negative, we mostly follow up the patients. But of course, if you ask me, like the next question I'm able to see is what are the difficulties you face?
Yes.
The most important difficulty that we usually face is when we have like equivocal reports, like there has been a mediastinal mass and at the end of the PET shows there is a mass, but there is no FDG uptake.
FDG.
You do a biopsy and then the biopsy comes negative. And you're not very sure whether the patient is actually in remission or not. In these scenarios, I think maybe in near future, if we do have lymphoma-based MRD, it's going to really help us in guiding the therapy.
Absolutely, ma'am. True. Absolutely. Because we face like every day, because the every patient comes in the hope that lymphoma is especially high-grade lymphoma is a curable disease, and low-grade lymphoma, we want to achieve a long-term remission. So, and whether we are kind of telling real truth to the patient, oh, your PET is negative means you are cured. But that's what we are facing a lot of problem with that one. So that's why we need to have a kind of a robust MRD. I think there's a definitely need. I think we in the first setting. So what is the ideal marker in lymphoma? Because instead of like in leukemias, we have I think we want to know how much is the tumor burden is in the initial diagnosis, and when we give a treatment, at the end of the treatment, we want to show it is negative and it achieved the kind of a extremely low level of this one. And obviously, if there is a residual disease is there in case of kind of a low-grade lymphoma, see how much is the residual lymphoma is there, even in a minute amount, which is undetectable by the conventional methods. And next is to find out the early response for early relapse, because whether we should be treating the lymphoma, especially high-grade lymphoma, is in the early stages or not. That's what the big question is, isn't it? So obviously, the methods in MRD in lymphoma, it comes to the yesterday discussion about the liquid biopsies, isn't it? Like the main thing is to find out ctDNA, like tumor DNA, circulating tumor DNA, which is obviously the term is this beautiful term, and derived to the circulating free DNA, and it can be done with the liquid biopsy, peripheral blood, and there are a lot of many studies are going on, and they are definitely in the in a trial and in the labs. Okay, and there are different methods of identifying this circulating DNA, the tumor DNA, and tumor cells. It's mainly the PCR based, and obviously even the flow cytometry is useful in some of the lymphomas, not necessarily everything. And next generation flow cytometry, which is very sensitive to that one. And the PCR based, like mainly the allele specific oligoclonide, I think probably the lab, any of the fantastic research lab, they are very proud to do that one. And obviously the NGS is, we heard quite a lot about NGS in last 2 days time. And sorry, this is a small slide, but what it is, like whatever, like in last 2 days, it's the same thing applies to here. All these are fantastic sensitive tests, and when you comes down, the sensitivity kind of improves, but it kind of like one is expensive, then availability, and the expertise interpretation, like how you're going to interpret these tests about it. Okay. I thought of just we'll go through all this lymphoma and where is the need for the lymphoma rather than like, yes, I got all the tool. No, I just want to see how we're going to, in the future, how we want the MRD to be. Yeah. So DLBCL, as you know, is the most common lymphoma, and 2/3 of the patients are cured with the first-line treatment. In India, we give our CHOP, and obviously the Pola chip is the standard of treatment everywhere. And in a young and fit young patients, we Pola chip is a standard one, and whatever the 1/3 patient who relapse, we have a very good salvage treatment. And salvage treatment, obviously we salvage with the conventional high dose chemotherapy and transplant. Obviously there are CAR T cells which are very good, and obviously stem cell transplant is a one. But still, again, we are stuck to the imaging is the one where we kind of monitor. And interim PET, as you mentioned, you do interim PET, but still it's not kind of like we don't guide us like whether to treat or not to treat, whether it's there or not. Okay, so that's what is the in DLBCL we haven't got the proof at the moment. Okay, so obviously, there are studies which have shown that having good MRD in research trial. I mean, what it is like in this one of the trial at the Rose et al. They showed that if there is they're MRD negative and which is detected by the sensitive NGS test, and who did not clear the get a proper MRD in after 2 cycles, they had a primary resistant disease. It's so nice to have such a information when we are starting the treatment, and after 3 cycles, like Hodgkin's PET, like we have this information so that we can immediately go to the salvage and go for a transplant. So there is evidence is there to start to begin with whether the patient is having a good response or not only clinically and radiologically. If you have some kind of a this method also is important. And there are a lot of studies with so many, especially the POLARIX trial, where the Polar chip and our CHOP was the kind of standard treatment. And the early, there is a role of early, when they are like their MRD positive of the treatment, they had a bad prognosis, whether you are in a Polar group or only the R-CHOP chemotherapy group. Okay, obviously we had excellent talk on post CAR T cell monitoring, like how to monitor and those things, and even the post treatment MRD monitoring also predict how the patient is going to whether they're going to relapse or not, and start the end of the treatment. So there are definitely clinical trials which have shown the very good data about like how we can use this data. Okay. So if it's available, how are you going to use it? So just kind of an imaginary question, but still, whether we should be prepared for that one anyway. So anyone, any of the panel members?
Like in DLBCL, there are various like ABC or GCB or primary.
Yes, of course, yeah.
And then, which can have like the more of ABC and primary medicinal, they are more of a higher rate intense regimen.
Exactly.
In those cases, I think MRD can be used.
Absolutely.
So like
yeah.
directly you can go for transplant in those cases. But in like if it is GCB, then we can go for less intense regimen like R-CHOP, or you can go for less DIPOC or Pola.
No, absolutely, because that's what like we want to know the information earlier on the treatment, so that we can guide, like we can whether to give like a simple R-CHOP, or although it's not simple one, but still whether to add something else or go for a direct DIPOC, or I mean, especially with double hit and triple hit lymphomas, we need to be using that one, and especially using such a high intense double hit and triple hit lymphoma with the DIPOC, especially in Indian scenario, is very difficult. So probably early kind of a response would be really useful. Yeah. Okay. So.
Also, we've seen in various trials, we've seen that those patients who are showing a late response and then defining those from those who have an early response, maybe after 2 or 3rd cycle, if you're doing an interim MRD, they have a higher chance of your relapse. So even that is a good, I mean, you can take it as a prognostic marker and guide your future planning of the patient. I mean, not only picking up relapse when the patient is not clinically relapsed and we are trying to pick it up early, even those who have, responded late, we know this patient is going to be bad.
Bad. Yes, exactly. And that's so important to have this information when we are counseling the patient about like what's the next plan is. Okay. Obviously, comparing images, we discuss about comparing and especially after the treatment, when you do a PET scan, at the end of the PET scan, yes, you always end up with some controversy or the other, what to do with these such a patient. So whether we should be doing like a 3-month, after 3 months repeat PET, or to go for a biopsy immediately, or like so many questions. We are still going in the like a multidisciplinary meeting discussions. Okay, so those are the questions we would like to have this one. Okay, and especially this DLBCL is such a curable condition, so we want to have some good information to treat this one. Yeah. So next thing is follicular lymphoma, which is a second common lymphoma and mostly non-curable. Okay. And especially with the lymphomas in elderly, follicular lymphoma in elderly, we find that like when you complete the treatment, you end up with always some residual disease, which we don't know what it means. I mean, okay. And after that, we kind of go for a maintenance treatment with the rituximab, whether obviously the studies have shown that maintenance rituximab has helped, and they put the patient from MRD positive end of the treatment induction to on maintenance after the maintenance. The studies show that remission duration is most likely a reflection of the quantity of the residual disease. Okay, so quantifying BCL2 IGH rearrangement, which is a common method in the MRD in follicular lymphoma. Obviously, the newer NGS methods, and they're absolutely brilliant, but still in a laboratory setting. Okay, so end of induction treatment MRD, many trials have shown that if they are negative, means they have got a very good PFS, and probably OS is difficult to say, but PFS is at least we can say. In early stage FL in a mirror trial, it's to guide. There is a trial between as a post involved field radiotherapy, whether to do some immunotherapy with a Zevalin or not. So that trial has shown that if they are like MRD positive, then you use Zevalin, and probably you have a very good response at the end, and very good PFS. And phase 3 of this in high risk follicular lymphoma, she shown the PFS of benefit with the patients which are MRD negative is about 34 months, is about 72% in MRD negative and about 39% in MRD positive patients. But whether we have kind of, we need to go for a consolidation, whether to go for a maintenance, there are mixed studies. There are a couple of studies which shown that we have a mixed response about these things. Okay, and still we don't know about those questions. Okay, so just like again how do you want to have MRD in follicular lymphoma patients like?
In follicular lymphoma, it is usually good to see by PET CT, but since it is less FDG avid than the higher intense, so and the survivability, overall survival is more than 10 to 15 years. So like for how long, like the patient asks for how long do you do PET CT, and then that is not.
Yes.
And so that is more, yes, since PET CT is more invasive or more toxic sometimes, then it is more financially, it is more higher cost. So doing MRD in follicular lymphoma, especially if they have high risks of progression, then we can do that.
It is, especially for the young and which we don't know what we have therapeutic options available. Ma'am, your
I'd
comment.
just like to add one
Yes, please.
important
Yes,
thing,
ma'am.
sir.
Yes, ma'am.
So our experience in Indian scenario,
Yes, ma'am. Yes.
most of our patients in follicular lymphoma in whom we put them on rituximab maintenance,
Yes.
especially those who come with a large tumor bulk. The biggest problem which we face is recurrent infections, including patients who have got nothing to do with the disease because of rituximab maintenance continuously. Most of these patients, after 3, 4, 5 cycles of rituximab maintenance, they'll end up going into the ICU.
Okay.
So
Yes.
if that is so, then if there is an MRD available in the near future,
Exactly.
then
Exactly.
probably if the end of treatment PET is in complete remission, and if these are patients who are MRD negative, then that would probably be a very good marker for us to decide who are the patients we actually want to consolidate or put on maintenance, and who are the patients who can just be on a monitoring with an MRD negative status. That would bring down the burden of infections and ICU admissions to a great extent.
Absolutely, absolutely. Because it's like the infection risk, especially with such a hypogammaglobulinemic state, and obviously we keep on giving rituximab, not to kind of the immunoglobulins have not recovered at all. So there's a high risk of that one. Yeah. So that's the one thing we kind of probably eventually we'll see that one. Okay. Yeah. Okay. So this is the follicular lymphoma where we would like to know where, especially the young patients, whether we should be, I mean, the question about here, whether to see them early, whether to pick them up early, I don't think probably is not a big thing like a DLBCL, because follicular lymphoma, even if they relapse, unless they are symptomatic, we don't treat them. But as you rightly said, probably whether end of induction, whether we got a good remission, then whether we should be stopping the treatment, especially in elderly patients who are risk of infections, which we don't want them to die with the infections. Yeah. So that's where we would like to have a good MRD. Yeah. Next comes to the mantle cell lymphoma. Mantle cell lymphoma is uncommon, but sometimes it's quite a low grade. It's an indolent course, and sometimes it's an extremely aggressive one, which is not curable one. So and like FL is characterized by 11-14 translocation with cyclin D1 expression, which is a useful tool for the monitoring. And there are many studies. Obviously, among the lymphoma, this is the mantle one is which has got a more MRD data than anything else, probably because. I remember working with Dr. Simon Rule, who was doing a lot of MRD work in this one. So still, obviously, the circulating tumor cells DNA by NGS and flow and other one we use it, and RQ-PCR to target this IGH clone rearrangement. These are all the in the trial stage here. So there are a lot of studies which shown that having a MRD in young patients with the cytarabine, the role of cytarabine was initially detected by because the cytarabine in young patients, we want to get him to remission and probably transplant them. You use quite a lot of mainly the cytarabine based treatment. Yeah, you can use any combination, or sometimes you use like a cytarabine and dexamethasone as a single agent also. And it showed that if you use this hydrocytarabine and if you do a PCR, and the study shown that they did a MRD on induction and consolidation or maintenance treatment, and the post-induction was is an independent risk or prognostic marker. With the 2-year remission rate was in young patient is almost like 100% compared to 65% who are MRD positive. Okay, in elderly is about 76% versus 36%. So there's a huge data to kind of to suggest us like if they are in MRD, going to MRD is such a useful tool. Okay, and in prognostication also in MCL3 study, patient treated with MRD positivity had a poor PFS outcome, and this is the post transplant MRD. Yeah, so post transplant. Obviously, for anything, probably pre-transplant in lymphomas, if you got a disease bulk, although we can detect a disease only with the radiologically, but if you have a tool to kind of predict that if they have got MRD negative, then the chance of long-term survival would be really good if they are MRD negative. Okay, so obviously these are like a new tools which definitely help in the future as well. Yeah. Obviously in mantle cell, although there's a lot of data is there, and how best is to use the MRD, there's a big question still there, and how to interpret the test and how we're going to intervene during these things. Okay, do you have to say anything, ma'am? So it's about a mantle cell.
Only theory which I have read. So
Yes, exactly.
that we can, because mantle comes with the cyclin D1 mutation.
Yes.
It's one of those where we can employ NGS based techniques which are way more advanced compared to the flow cytometry or the PCR based techniques.
Yes, yes,
But
yes.
that's only theory.
Yes, yes, but still, because mantle is the one which is like very interesting, but obviously is such a aggressive in few patients, even especially young patients. We have burnt our fingers with only giving small chemotherapy. I mean, like a usual chemotherapy, but not going for the transplant. Although we tend to advise them always. But the MRD probably would have been best to, like, say, if they are still positive, definitely go for a transplant. Yeah, that will guide us. Yeah. Anything, ma'am? This one. Yes.
Mainly like in lymphomas, like there is a staging. Okay, like in early, if the patient has early staging, but the disease bulk or the disease burden by NGS is high, then I think that would guide us towards making treatment decision rather than just looking at the PET and telling, okay, this is stage 4 or 3, or if it is stage 1, all the patient has stage 1 disease, and but the NGS based method, if it tells, okay, we have high tumor burden, then okay, you can go for high
not
intense
responding. Then
regimen, yes.
yeah, it must be
Especially
still
after the
positive.
treatment, yes.
Probably we should not be relaxing. Just go with the big guns, isn't it? Yeah. So obviously I kind of a discussion is about like probably is more about these things were all discussed in previous discussion about like how good is PCR method, how good is NGS methods, but the accessibility and the cost is still there, and the obviously usefulness still in the clinical practice is still on the trial setting. But so do you have any doubt about role in MRD in lymphomas? Because the question they ask is, so does it have a role? So what do you think? I mean, that's probably we'll have some.
No, definitely it does. I
It
mean,
does
all the
have-
clinical trials have shown both.
Exactly, yeah.
It's just not been in. There are some newer trials which have come out. I think fall 12 or something, where they have used it to upgrade the treatment too. I mean, that is applicable for the treatment that they are trying, and it's actually helping those. Just as ma'am pointed out, whether a patient your is MRD negative, and then we would like to put him on further treatment.
Exactly,
If his your PET negative, MRD negative, should we follow him up with or more treatment or just keep him observation? Those things we can still come up with new guidelines. They can guide our treatment based URA. And also it has also been seen when you are combining your PET with an MRD, even then the prognostications become even better. That also you can do.
Yes, that's right. I mean, there's no question about it having. Please, ma'am.
No,
Your
nothing,
turn.
sir.
Yes.
I would just like to say this,
Yes, yeah.
that vision of today is reality of tomorrow.
Exactly.
There was a point of time when we had only imatinib and we never had any TKD mutations. We were so happy managing CMLs with only imatinib.
Yes, yes.
And today we are falling short of even ponatinib and asciminib.
Yes.
And we have all the panel of mutations which we used to read upon once upon a time in reality, and we are making use of it very much.
Yes.
So what we are thinking of as MRD in lymphomas as a vision today will probably become a practice maybe 5-6 years down the lane. And that is when we will be using the MRD in lymphomas to guide the treatment decisions. Whom to take for transplant, whom not to take for transplant. These decisions will probably be guided by the MRDs.
Yes, I mean, absolutely, because there are a lot of newer drugs are available at the moment, and like how to do with the maintenance, whether just simple rituximab is useful or whether you add some imids for the especially mantle cells and which are useful. So there are a lot of things which we can answer with if you have a good MRD data and practical tools. Okay, so obviously there's no question that MRD has a definite role in lymphomas, and especially when the new treatments are available, and to mainly to detect the refractory cases to escalate the treatment, and second is to detect the early relapse and start the treatment soon in high grade lymphomas. And obviously the current modalities treatment, the modalities of detection, they need a validation or time consuming, need expertise to interpret, and that they are expensive. But need of the hour is still in infancy stage, but child is growing faster. So that's what we hope for. Okay. Thank you very much. Thank you. If you have any questions, yes. Thanks.
Thank you.
Or any kind of a comment also, like I don't think we have any answer. I can answer that. If you have any comments, please. Yes. Sure. Thank you.
I had a small comment is
Yes,
that
please.
the lymphoma is also a compartmental disease. So mostly, particularly for DLBCL, you can have CNS relapses, whereas the body is completely negative. So that is another hurdle probably in the monitoring of patients with MRD that we'd also need to monitor, because even PET-CT doesn't monitor the CNS disease well. So there is another need to monitor the CNS disease also when we are thinking of MRD in lymphoma.
Absolutely. Absolutely. Thank you. Thank you. Thank you very much for the kind cooperation. Thank you.
Thank you everyone for such an interactive session. Thank you, Chairperson. Thank you, moderator. Thank you, panelists. We have a quick announcement. We have the Best of ASCO happening at HCG Mumbai in October 2024. So moving on to the last session before lunch, it is a talk on chimerism and its significance in MRD, for which I would request the chairpersons to kindly grace the stage. Dr. Sachin Trivedi, medical oncologist at HCG Mumbai. Sir is not present. Dr. Bhuvan Kishore, MBBS, MRCP, FRC Path, University Hospitals, Birmingham, NHS, FT. Welcome, sir.
Thank you. May I thanks for the introduction. May I please welcome Dr. Shantanu Sen from Kokleben Hospital, consultant pediatric oncologist, for his talk.
And it looks like we could have done this over a cup of tea. But thank you all who are here with us. It's always kind of, my slides are not there. Can we? Perfect. So it's always very interesting. It's so Calcutta is kind of my hometown. I still have my house here somewhere. And it's always a pleasure to come back. And having breakfast with Luchi and Aloo Tarkari is a pleasure. So with that little detour, let's talk about chimerism and how does it affect and how does it tie in with MRD. So why do we do chimerism? Well, it's kind of when you do a transplant, you want a number. You want to see that you've been successful in doing that. And it's our first measurable, quantifiable marker for a successful transplant. We measure it at day 14, somewhere between 14 to 21, when we know that we have had engraftment. And subsequently, it's become a kind of a policy or like a tradition to do it at day 30, day 60, day 90, then at 6 months, 1 year, sometimes at 2 years. And we always follow this chimerism as a transplanter because whenever it drops, we get a bit of palpitation. That if we are working in a non-malignant setting, doing it for a thalassemia or an aplastic, we worry, is the graft failing? And if it's in a malignant transplant that we do, if it happens, What we worry about is the disease relapsing here at this point of time. How do we measure chimerism? Again, the standard is using the short tandem repeat panel analysis. And this this panel looks at some specific and differentiating unique STR signatures that are different between the patient and his or her donor. And once we look at those signatures at different points, we try and find out what is the quantitative information. So sometimes what happens, and this has happened to me very recently, that if you're doing transplants as in a matched sibling donor, and I do a lot of thal transplants, and I have at least 2 patients where the twin is the donor for the other twin sibling. And sometimes then my geneticist calls back and says that I cannot find differentiating STRs. So if something like that happens, what you can do, you can increase the number of probes and you can ask your lab to do that. And rather than looking at 4 unique probes, they can increase it to 9, they can increase it to 12. And usually by that, they will find something that's different between your 2 patients. But there are some issues when you are measuring chimerism with STR. There is a lack of standardization. And the other thing, which is actually quite important, that STR is actually a qualitative tool that we are using to get a quantitative measurement by looking at various data points. So by itself, it's not a quantitative measurement. We are using a software, computer-based algorithm to look at these data points and change a qualitative measurement to a quantitative. Now, it is inaccurate at very low levels. And certainly these limitations of lower sensitivity, especially when you're looking at microchimerism, means that we need some newer ways to measure chimerism. And much like MRD, we'll talk about things that are very similar. Now, sometimes you might have your patient and donor being a brother or sister or father to a mother, i.e. you have sex mismatch transplants. And if that happens, it's actually very useful to do a FISH for X and Y. You get very rapid results. If we send a sample in the morning, our lab calls us back by next day in the morning or even by the evening sometimes and tells us what the FISH is. It's extremely rapid. STR, as you know, will take about 5 to 6 days depending upon how your lab functions. You can do a quantitative PCR, which is very highly sensitive method. We've been talking about MRD by qPCR, and again, the same kind of technique can be used to measure chimerism as well. And if we are talking about qPCR, you know this is coming, which is NGS. And I think this is the world that we are coming to. We want to get much more information, and certainly a next generation sequencing looking at these data points can help us actually find out what percentage is the donor cells and the recipient cells with much greater depth. What are the differences? So NGS is inherently more accurate, more precise than either an STR or a qPCR, especially when you're looking at mixed chimerisms between the 95 to 100%. It's that point where it's very, very useful. It's more sensitive. It can measure up to 0.5. And even if you have scanty samples, it can actually give you a very, very valid result. It can give you more informative markers using the same samples. It's got more reliable. We know this. NGS can help us, and then you can use it to understand whether you're having a disease relapse or a graft failure. Chimerism and GVHD goes hand in hand, and we know this, that if you have high and full chimerism, you have more GVHD. But again, as you can see, and this is common knowledge, that if you have GVHD, it does translate to better survival, because GVHD in a malignant setting equates to graft versus leukemia or graft versus tumor effect. When you have falling chimerism, you can have less GVHD, but as we discussed this morning, it's not an absolute. Sometimes you can have GVHD even with a falling chimerism. And then again, if you're reacting to that by giving DLI, you will precipitate more GVHD because these things will go hand in hand. I'll speak a little bit about split chimerism. What we have mostly here in India is what we call whole blood chimerism, which basically looks at all the cell lines. But we can use a cell sorter to actually separate out the cells into the Ts, the Bs, the NKs, and the myeloid cell line, and look at the lineages, this lineage-specific chimerism, looking at both of these, and try and find out how much of it is from the donor and recipient. Is it useful? It's actually pretty useful. And there's a very good paper which looked at lineage-specific chimerism monitoring in patients following a transplant. And I'll just, let me just see if I can get a pointer. Yeah. So I'll just draw your attention to this little bit of a violet curve out here. And this is all patients. When you do split chimerism, you can see these are the T cells. The T cells don't engraft early. The T cell takes a long time to come to normal. In fact, it's 12 months is when it kind of reaches a little bit like a normal level. And this is the reason post-transplant, we get a lot of viral infections because your patient does not have functioning T cells. It also depends upon the disease for which you're transplanting. Certainly, if you're doing for a bone marrow failure or severe aplastic anemia, your Ts take a long time to come back to normal, as we talked about. With thalassemias or sickle cell disease hemoglobinopathies, initially, the markers are all very normal because you're really looking at your myeloid engraftment when you're doing a thal transplant. And usually that's good, but you got to watch the patients very carefully between the 9 to 12 months because that's when the chimerism can take a dip. And that is why when you're doing a transplant for either a thal, a sickle cell, sometimes even aplastic, you need to keep your immunosuppression going for longer. You don't stop it early because that's one of the things you need to do. Similarly, we look at bone marrow failure. We have a drop in T cells early. Engraftment only happens around about 2 years. Similarly, with hematological malignancies, this is the ALLs and AMLs. Again, it shows the same pattern that T cells take longer to come on. Primary immunodeficiencies is a kind of exception where your myeloid engraftment can actually be quite late. But I want to show you this one. It also depends upon conditioning. If you have a T cell depletion, obviously your T cells will be low before coming back to normal. Unmodified, it's about the same. But we in India have given up cord transplants. But if you do a cord transplant, look at those graphs. They are perfect. You have your Ts and your myeloid cells because it's such a primitive cell line. If you can do it properly, your engraftment kinetics stays beautifully flat. Now, there are some principles when you're treating malignancies with a BMT. I mean, previously, we used to think that let's give our patient more chemotherapy, higher doses of radiotherapy, let's eradicate the disease from all sides. But that actually is not a very good plan. It's not a very good idea because that would lead to more increased transplant-related mortality, increased organ toxicity, and the damage that your chemo and the radiation will do to all the mucosal surfaces means that you get a lot more GVHD. So a better and a kind of like a cleverer way to do it would be to do a reduced intensity conditioning, but we need to ensure that we have got good donor engraftment to maximize our graft versus leukemia, graft versus tumor effect, and minimize GVHD. We will use DLI, and we'll talk about that a little bit to augment GVL as needed. It will come at a cost of a little bit of increased GVHD. Is there a relation between chimerism and relapse? Relapse is part and parcel of a transplanter like me, and it's something that we struggle with. We get patients who are very, very bad. We do a transplant, but again, depending upon the disease, 20 to 80% of them will relapse. We want to try and detect them as early as we can so that we can either give them an additional therapy or we do a DLI. And sometimes this will be very useful. And for these cases, either using MRD or chimerism can be useful. So I just want to talk about a few working definitions. Ideal situation, your patient would have 100% donor cells, which is complete chimerism. Traditionally, full donor chimerism was defined as any chimerism more than 95%. But nowadays, we kind of has teased out a little bit difference in there. We call, there's another entity called the low-level mixed chimerism, where your donor cells are between the 95 to 99. And this one is actually important to know. Mixed donor chimerism is a massive range, 9 to 95. But IMC is an important concept. IMC, or increasing mixed chimerism, is when you have two subsequent reports showing a drop or a decrease in chimerism. Of course, if you don't have donor cells, that's defined as anything less than 5%. So if you keep these definitions in mind, we kind of go to the next step. We see how we can use it. Now, there are some caveats. We know that increase in recipient cells means that your patient has a greater chance of relapse. But you got to remember that chimerism measurement is basically a genomic differences. We quantify what is the difference in genomic DNA. But this may not always represent the leukemic relapse. So sometimes you can have a drop in chimerism, but you may not have a relapse. But overall, if you take a whole group of patients together and you follow them and you see there's a drop in chimerism, usually that would mean there's a relapse there. So I have a few papers to go through. So this is one of the papers that came in BBMT, where they looked at what's happening and what is the predictive value of donor chimerism on disease relapse, GVHD, and survival in a cohort of about 120 patients. And all of them were transplanted with a very uniform RIC transplant protocol with fludarabine busulfan. They had standard GVHD prophylaxis, and their immunosuppression was all absolutely same. And look at this. So we can see that when we have whole blood chimerism that was absolutely good, our incidence of relapse was low. The minute the chimerism started to drop, that's when our relapses would go up. There's also a concordance with T-cell chimerism, and they had taken a cutoff of 65% and found the same thing. But basically, for every just 1% drop in chimerism in whole blood, there's a difference of 10% in relative risk of a subsequent relapse. So chimerism is actually very useful. And they actually kind of used this data to say, what is the projected risk of relapse 1 year for these patients? That if you have 100% chimerism, only 21% of your patients will relapse. That's pretty good when you're dealing with a malignant transplant. When it drops to 95, it goes to 34%, still is acceptable. But when it drops to 90, you're going to have 50% of your patients that will relapse. So they said that this is their inference, and I kind of agree that it's a major advantage that you can do it in all patients, even if you don't have any disease-specific information. And that's because MRD, you need to have a known immunophenotype or molecular abnormality that you need to kind of follow up. And even though MRD has been questioned at times, it's kind of a little bit difficult to see. And especially after RIC transplants, you might have a little bit of MRD that's still there because of residual malignant cells that will still be there. And this can be affected and taken care of by potent GVHD. So we can actually react to the dropping chimerism early by whatever, reduce your immunosuppression, give some DLI, give some targeted therapy, and have a better outcome. There's another paper which looked at about 100 patients of ALL, and they all had a myeloablative. For the last paper looked at more of a MAC regime, RIC regime. This is a more of a MAC regime, and it's a TBI-Cy or a TBI thiosulfan-based protocol. And again, we have something very similar, but there is an interesting bit in this paper. So remember, I was telling you about increasing mixed chimerism, where you have mixed chimerism that's kind of dropping a little bit. So that's this solid bar. And if you have an increase in mixed chimerism, these are the patients that are kind of really rushing towards a relapse, rushing towards their disease coming back. I mean, of course, if you have complete donor chimerism, it's all good, or de-escalating is fine, low level is fine, but increase in mixed chimerism is one group that you need to look at. So if you're doing transplants for malignant patients, and you see that your chimerism is slowly dropping, it was 100, then it's 99, then it goes to 95, then it goes to 94. That's the patient you need to be very careful about. Something very similar, again, they looked at with MRD. And again, this is what we've been talking about for the last 2 days. We know that if you are MRD negative, you do well. If you're MRD persistence, you don't do well. So this is what we said, that increasing in mixed chimerism is not good. And this is the patients where we would be actually looking very closely to see how we deal with it. Now, there is a difference between looking at this with MRD and chimerism. Certainly, relapse prediction by MRD is more sensitive and specific than chimerism, but the way I look at it, that they will go hand in hand. You got to use all your tools, and rather than say that I'm just going to use one and not use the other. Again, something similar looking at chimerism after with a longer survival time, and this is a big group of patients. And what they looked at is basically that if it's longitudinal chimerism measurements, and that's what I talked about when he said that you track your chimerism over time, and that is highly predictive of what's going to happen to your patients over time. So overall inference is that we have multiple studies to say that there is an association between chimerism and relapse, and even a 1%, a small drop in chimerism, will increase the relative risk. So we can be using chimerism to guide early post-transplant therapy. We know what's the difference and which can we use. Sensitivity of little bit of increasing microchimerism is lower than MRD, but sometimes this can precede an MRD change that can happen later. So as the way I was saying, that we have to use both together to actually find out what's happening. I mean, we talked about the ways of we detect, we covered that we can look at various cell types, dynamic testing, but I want to go to this. So what happens that if you have a patient whose chimerism is dropping or your MRD is positive, what can we use? That we can either use DLI, we can use hypomethylating agents, or we can use some targeted therapies. And DLI, basically, it's kind of precipitate a little bit of GVH, graft versus leukemia effect, but it also has a little bit of direct anti-tumor effect. Hypomethylating agents, we know how they work. So this is basically a little bit of data about DLI. And the main reason I put this paper up was basically to kind of show you something, that this is about 120 patients who received DLI after a transplant, and the treatment was given either because of a hematological, a molecular, a cytogenetic, or other causes. Now, when you look at the surviving patients, when you have reacted to it at the point of actual hematological relapse happening, the outcomes are not great. But if you can identify these patients early by cytogenetic or molecular markers, then at least there will be a significant proportion of these patients that you can save. Azacitidine, we know how it works, and there I've just kind of mentioned two trials. The RELAZA trial, which is relapse prevention with azacitidine. This was a smaller trial looking at a single center, 4 cycles of azacitidine standard dose every month. And what they looked at is what is the response when you use it in the face of imminent relapse in MDS or AML. And basically, it says that it has got a good safety profile. It can prevent or delay relapse, and certainly it's something that we all use in, day out. And this led on to the RELAZA 2 trial, which was a larger multi-phase trial done in Germany in patients with MDS or AML, complete remission. But then after that, when you are getting prospectively screened for MRD or a drop in chimerism, that's when you treat them. And again, same dose cycle, but rather than limiting to 4 cycles, they carried on for up to 24 cycles. And the primary endpoint for them was the proportion who are relapse-free after 6 months. And if you look at it, we can see that it's actually a pretty good drug to be used in our patients. That if you are MRD negative, then it's all good. But even when you are MRD positive, relapse-free at 12 months was 46% who are MRD positive. That's kind of, you're still able to salvage about 50% of patients with this. And finally, we were using sorafenib in patients who are FLT3 ITD positive. And we know that if you're using sorafenib, your outcomes, chances of relapse are better. Overall survival is much better. So leukemia survival is also better. And this is another drug that we're using in the post-transplant setting. But I think we have a lecture on that, so I'll go on for that. So if I sum it up, what are the thoughts? We know that disease relapse is now the most important cause of treatment failure post-transplant for patients who have a high-risk disease. And certainly, if we can have earlier detection by whatever diagnostic tools, we can identify these patients and treat them appropriately to try and save them. MRD assessment, we have always had that. We have advancing technologies, which we talked about for the last 2 days, and more molecular markers have been discovered. But we have some questions. Is there any additional consolidation therapy we should give to the patients to eradicate MRD before transplant? Yes, of course, we talked about in the last 2 sessions that if we can manage to give our patients additional therapy to make them MRD negative, our transplant outcomes will be much better. Is there an impact of MRD on donor selection? Can we do something like we can deliberately choose a haplo donor who's kind of a little bit different to precipitate more GVHD? Does it have an impact on conditioning regimen? And what would be our best approach when you have a persistent MRD or early relapse? And the other thought is with chimerism, especially increasing mixed chimerism, how do we do it? So the way I actually looked at it is that chimerism is a complementary test together with your MRD. And you use both to decide how you're going to react to your patient in somebody who's kind of having at that phase that the disease is about to relapse. So takeaway points, increasing mixed chimerism is associated with relapse post-transplant. So you need to have close monitoring post-transplant to detect an early relapse and kind of intervene earlier rather than later. Highly sensitive NGS-based chimerism will possibly overtake STR at some point. And we were talking about, even though we are all doing STR at some point with NGSs coming through, we probably will be shifting to that. And that will allow us to have earlier detection of mixed chimerism compared to STR. And we have better prediction of disease relapse. That's kind of what I wanted to talk about on this topic. And I just want to invite you all to the Histiocytosis Society's annual meeting that's going to be in Goa in November. And we have a whole plethora of big names in HLH coming with us. So I hope I'll see some of you there. And thank you so much.
Thank you for that lovely talk. Before we go to questions, I would like to welcome my co-chair, Dr. Trivedi. He has joined us from Mumbai. Fantastic. So great talk. And just a couple of questions and thoughts from you. So you mentioned that reduced intensity conditioning will be most of the adult patients. And if the relapse happens, then it's very difficult to salvage. Very rarely we salvage AML and ALL patients who have frankly had hematological relapse. You may be aware of the Figaro trial, which showed that if you have achieved full donor chimerism, but defined as 95%, then you have very little chance if the MRD is positive or negative. That doesn't impact much, but the full donor chimerism does have some impact. So how would you take a patient through their follow-up MRDs and chimerism tests? You had mentioned some time points, but when would you intervene with DLI? What would be your critical time limits?
So AML patients.
AML, and then if you want to expand it into ALL as well.
Okay. So I can tell you the practice that we follow, which is that if we have an AML patient, we know that these are the patients that when they relapse, we don't have much. So what we normally do is that we would actually check. I mean, you're checking for GVHD on an ongoing basis. So day plus 45 and day plus 90 are the 2 time points when we actually do a bone marrow on our patients. And we do chimerism and MRD on that samples. So if at both of these time points, we find that they are MRD negative and chimerism is very good, but they have absolutely no signs of GVHD, then we start getting a little bit worried, because I think we are a little comfortable seeing just a little bit of GVHD, even if it's a little bit of a rash, some slight diarrhea. So then we actually sit down and say, okay, we have a patient that we've managed to keep very well, but we would like to see a little bit of GVL happening there. So those are the patients we kind of give a very low dose of DLI and follow up. Now, of course, at either of those 2 points, we see dropping chimerism or MRD becoming positive, then it becomes very easy decision for us to say, we need to do a DLI for them. Yes. So any malignant transplants that we do, we would very actively start de-escalating cyclosporin as early as day 45 to day 60. And by 4 months or even earlier, by day 90, most of our patients, if they have no signs of GVHD, will be off all immunosuppressions. If, however, I kind of said that if it's a thalassemia or an aplastic, that goes out of the window, because those are the patients you need to keep them on immunosuppressions for a much, much longer time. Malignant transplants, you want to take it off as early as possible, promote some degree of GVH, GVL coming in as early as possible, and kind of take off the cyclosporin as soon as possible to make that happen. If your patient has some degree of GVH, then be more cautious about removing it that early, seeing that if that's what's keeping it safe. Yeah.
Prophylactic BLI.
Yeah. AML, yes. ALL, we don't.
Yeah. So I'm a medical oncologist by profession. So humor me for a bit, okay? I'm a bit naive when it comes to your transplants, but there was a couple of things that actually stood out. One is adoption of the newer technologies. The one question I had that you presented seemed a bit counterintuitive to actually club both the non-malignant and the indication and the malignant indication for transplant, where you said that you could actually, in the modern scheme of things, you might want to de-escalate in terms of not doing whole body irradiation, other things. Is there a difference the way you treat hematological malignancy versus a sickle cell or something else when it comes to doing that kind of approach?
Actually, I think I messed up that I actually should not have brought in non-malignant into this at all, because this whole thing is all about malignant transplants. But to answer the question that each and every disease that you look at, whether it's thalassemia or sickle cell, your transplant protocol changes completely. So if it is a malignant transplant like a thalassemia, there is no role for RIG at all, because in those conditions, whether it's a thalassemia or a sickle cell, your primary aim is that you got to wipe out that bone marrow completely. So by hook or by crook, you need to deliver a myeloablative conditioning regimen, whether that is a BUSI or what we use much more with is fludarabine, thiosulfan, thiotepa. There is no role for RIG in a non-malignant setting at all, except where if you are doing a transplant for a SCID or a primary immunodeficiency, because many of those patients, they are so immunodeficient, they don't need much conditioning at all, leave alone something like a MAC. And for those patients, you can just about take the stem cells and give it even without any conditioning and have a very good engraftment.
Thank you.
Do we have any questions from the audience?
So for so there are a couple of things. So, okay. So what we do, if I talk about the standard is actually 12 gray. And we use that morning and evening over 4 days, Monday, Tuesday, Wednesday, Thursday, 2 gray, 4 into 3. Oh, sorry. TBI. Okay. I'm sorry. Thank you. The first dose, if I remember correctly, is CD3 doses of 0.05, something like that, actually. I need to look at the paper. So we start with in practical terms, when you look at it, you take the donor, you have some of the stem cells that's frozen already. You don't touch that. You just do lymphocyte subset analysis on the donor. At the point you want to do a DLI, you find out what is peripheral CD3 counts is. Practical terms, what it translates is usually if you get, if it's a child and an adult donor, just 5 ml is fine. If it's an adult to adult, 50 ml usually equates to the first dose of DLI. It's rare for most cases when you're using prophylactic DLI to be needing more than 1 or a maximum of 2. Because usually within that, you will find a little bit of GVH coming in and then you just back off straight away after that. How soon after DLI you give the second dose? Check the chimerism, usually after 2 weeks. Second dose is after 2 months after that, and we follow up the patients.
Perfect. I think we should break up for lunch. Then we can
But before that, I think Sachin has got to say something about the meeting that HPC is organizing in Mumbai.
Shoaib, you made my day. I only come for the Kolkata biryani all the way from Mumbai. So yeah, so I'd like to invite you all for the Best of ASCO meeting in the Mumbai edition. So it's a licensed meeting, and Joydeep and I will be working very meticulously to curate the best thing, and we like your active participation in that. We want to keep it north of Bangalore, this meeting forever. So please participate actively, and yeah, hope to see you in October.
Break for lunch and back by 5 to 2, 10 minutes to 2, please, so we can start on time.
in such difficult AML patients. Then we move on to another case. Now, 32-year-old teacher, newly diagnosed AML, FLT3 ITD positive, normal karyotype. How will you approach this patient? Anybody can take this question. Anupam.
Yeah, 32-year-old, definitely fit. So standard way to go 7+3 induction with FLT3 inhibitor of choice. So like midostaurin as induction, followed by check the remission status, and again a transplant, means one more consolidation, followed by if you have a suitable match donor available, allo transplant. Should be my
Absolutely.
plan as a off discussion to the patient.
Absolutely. I mean, that's absolutely standard. The next question, probably Dr. Pranoti, from the lab perspective. In this sort of patient, what do you think about MRD? What is the best way to monitor MRD, especially FLT3 and a diagnosis? I mean, what sort of techniques do you think? What is more sensitive?
So I think the first approach would be because FLT3 we cannot follow up because it is very unstable. So that is not a good marker, even though it's a molecular marker. It is good for the treatment point of view. So we would see if it is possible by MFC, multicolor flow cytometry, to follow it up. And if we have the facility, or we can do it. And maybe we can also have an NGS for that future. We can plan later.
Okay. So thank you for that. So as we discussed in the morning, the FLT3, the RAS, these are also sort of signaling pathways, and they form sort of subclones within the AML. So although you have got at diagnosis, you get a FLT3, in terms of monitoring, it is difficult because sometimes the subclones can disappear and they don't really sort of inform you as to how the patient is doing. So the recommendations from the ELN in terms of FLT3 has been to monitor FLT3 just for in terms of positivity, but you need another marker. Like she said, you need a multi-parameter flow cytometry to monitor these patients as well. Now, this is data from the UK, where they've looked at, this is my colleague, Richard, who has been working with the AML team doing the MRDs at Guy's Hospital. And they've looked at FLT3 ITD as part of their AML trials. Now, if you look at this graph carefully here, what they have shown here is these ones, the red ones are PCR and PCR NGS positive, CE positive. So they're using the capillary electrophoresis methods. Now, the capillary electrophoresis method, this is the level of detection here, right here. Now, the green ones are your PCR NGS negative. This is your level of detection here. And then in between are your NGS positive, but CE negative, capillary electrophoresis negative. Then they looked at what the outcomes were in these sort of patients, what the survival has been and what the outcomes have been. So the take home here message has been that if pre-transplant, before going for transplant, you have an NGS PCR negative. So this sort of level of negativity here, your outcome is best. So these two graphs. Okay, so your relapse and overall survival, lowest relapse and best overall survival, once you do it with the PCR NGS, where the level of detection is very low. Whereas these patients, they relapse quite fast, or their outcomes are not as great as when you compare with NGS. But this is pre-transplant. And as we said, post-transplant, we really cannot monitor. So it is the pre-transplant FLT3 NGS monitoring before you go to transplant, which will dictate the outcomes in FLT3 positive AMLs. Then we go on to the next sort of question. Now, purposely, I haven't taken NPM1 and BCR-ABL because those are established markers. And we need to look at other things as to how we are going to actually inform treatment decisions or monitoring decisions when these two are absent. So just a question to the panel. Do you use NGS for pre-transplant MRD, or when do you use NGS, or how do you use NGS? Anybody?
we do not use NGS routinely. We've developed an assay for the DNA-based mutation analysis for NGS. We've still not made it standard of care for our purpose, but we do flow MRD before transplant and take our decisions based on that. Going forward, maybe we'll use, but we're not sure about the implications there.
Okay. Anyone else? No. Okay. So I would highly recommend looking at these papers. There's a group by Hauser et al. And Thal et al. This is a German group, and they've done a lot of work on MRD by NGS. Now, this data is pre-transplant MRD by NGS. So this is before transplant. Now, before I go into it, again, in the morning, we had discussed about markers for NGS. So broadly divided into two, we talked about the FLT3 NGS because they are subclones. We don't really monitor them. Then you've got two other types of mutations. One is the DTA, which is basically these are clonal hematopoiesis, which is your DNMT3A, TET2, and A6L1. Again, these three genes are actually excluded from NGS monitoring because they are part of clonal hematopoiesis and do not really inform you in terms of what's happening with the disease. So this is a data where they looked at their own AML patients who've gone for transplant, where they did not have any significant obvious marker like an NPM1 or a BCR-ABL, but had other markers present at diagnosis on an NGS, and they did a modified NGS protocol to detect mutations before they went into transplant. Now, 90% of their patients had a mutation, and they looked at NGS, and they looked at their cumulative incidence of relapse and their non-relapse mortality. And you can see here that those who are NGS positive here, the green ones, their incidence of relapse was the highest here. So basically, when you looking at the non-DTA ones, if you're MRD positive by NGS, again, that will tell you that your relapse is going to be the highest. Again, the same thing with non-relapse mortality and your relapse-free survival. I think if you're MRD positive, your survival is poor. So this is some data which has been generated, especially when we don't have a good marker like an NPM1, but something by NGS which will inform us how the outcomes are going to be if they're positive by NGS. Now, again, here the VAF level for an NGS to be positive or negative is at 0.1. So a VAF of 0.1% and below is considered to be NGS negative. Again, the same question. What about, do you use NGS for post-transplant MRD?
Again, I think we have to understand that it's good for prognostication. It's good to tell the patient that probably you have a higher chance of relapse or you don't have a higher chance of relapse. But the question again remains, unlike ALL, we don't have a answer as to what you're going to do with that positive report.
Exactly.
So unless that picture or clarity comes in, these are costly tests. So and you probably have to do it if you're looking at pre-post, then you have to do it at least 3 time points, which is baseline, pre-post. So I mean, unless we have the implications of what we are going to do with a positive report, I think to bring it into routine clinical practice will be a challenge. We do check MRD post-transplant because we think that if it's positive, usually would also reflect in the chimerism, especially if you're doing split, and then we can take an action as to intervene at that point of time. But I don't think the picture is very clear to us as to what we will do if we have a positive MRD. That's the problem.
Yeah, I think what Ajit has said, I was about to tell that MRD in clinical practice, no, but we give more importance and focus to the split chimerism actually, post-transplant monitoring and intervention. So MRD is not of in a clinical practice, but yes, if you have some very good marker at the diagnosis pre-transplant, then definitely you can do, but that is not applicable to all patients. I think 1 in 100 patient you can monitor like that, but
True.
Split chimerism is more of a value.
I didn't touch on chimerism because my colleague Shantanu Sen had a whole talk on MRD and chimerism. So I'm holding on to MRD. But I think this is just proof of concept to say that, newer techniques are being developed. And as you said, they are not widely available. And even if you do get a positive report on one of the mutations, how are we going to tackle it? I mean, unless there are specific inhibitors like the IDH1, IDH2, which are established, or even a FLT3, which are established, it is going to be difficult. And just because the molecular MRD is positive, going ahead and giving DLI with the risk of GVHD until we have got reasonable data, it's going to be slightly difficult. But again, this is something similar. You got patients who had who underwent transplant. These are 138 patients, allo transplant, and as we said, they in post transplant, no one has looked at these DTA mutations. So DNMT3A, TET2, and ASXL1. So they looked at those DTA mutations as well and the non-DTA as well, and this is what they found basically. So here they did not find. So with the DTA mutations, they did not find any significant correlation. So for example, if you look at the higher incidence of relapse here, the blue as well as the red ones, they are MRD positive, basically, and they're slightly bad. But if you look at the non-DTA mutations, the more MRD negative you are, the better you did. So in their sort of cohort, they didn't find any significant difference between when you did the DTA mutations. So I think that's all that I had to say today. The only other thing that I would like to know from the panelists is, in terms of flow cytometry and MRD, there's a whole emphasis on having the first pull to do the MRD. And when you do the flow cytometry, if your MRD is slightly positive and they are still morphologically normal, in terms of therapeutics, how do you go forward? For example, you did your day 30, it was negative, maybe you do it a day 60 or a day 100 flow, and say that because for the definition is actually still 0.1 MRD, say it has gone slightly higher. What would you, how would you approach it? Would you monitor closely, or would you do a bone marrow in that case, or would you plan for DLI? I mean, how would you? What's your thought process? How do you approach this?
I think for us, we'll definitely do a marrow, because we would probably expect a higher level of positivity in the marrow from the flow, and we will intervene unless the patient has got contraindications for it. We will intervene in terms of DLI. Yeah, we will do that.
So the MRD flow always you are doing on a marrow only, no? So there is no question of we'll do.
I mean, there is some data with sort of high sensitivity flow where they've looked at peripheral blood and bone marrow being sort of similar in terms of flow.
Yeah, so definitely if the better do in marrow. So if you are getting a flow MRD positivity, 100% marrow will be much
No,
more
absolutely.
positive.
So
Yeah.
then how do you approach it?
There is
Marrow?
nothing like wait and watch. Definitely we have to intervene by doing a DLI or something like that. And same time, we'll check the chimerism also. What is the chimerism status as well as your MRD status, and then you take your point.
Okay.
Can we add some medications, Sachin, maintenance therapy?
Yeah, I mean, exactly. I mean, that's
Amazing.
the other question. I mean, would you add any azacitidine? Some people use interferon to induce some GVHD. These are the things that people normally do.
As I primed DLI, lot of data is there.
Yes, sir. Again, depending on the GVHD status of the patient. So if there is some incidence of GVHD, probably we will go only ahead with an azacitidine. Per se, if he doesn't have, then DLI with azacitidine.
Rapidly tapering the immunosuppression also. If the patient is on immunosuppression, it's better to take it off quickly and then start your.
Okay, I think with this, I'm going to close the session. So basically, I'm just going to say MRD monitoring is important both pre and post transplant. The most clinical utility is going to be on the flow MRD because that is more easily accessible. NGS MRD is now coming into picture, but the utility is still probably more of prognostic value than of clinical intervention at the minute. We know the value of sort of BCR-ABL and NPM1 monitoring, how important that is. and FLT3 to some extent. We've seen about the pre-transplant FLT3 status by NGS is probably more sensitive to sort of tell us how the FLT3 AMLs are going to do. So with that, I'll close the session. And if there are any questions from the audience or any further comments which the panelists can answer. Okay.
Sir, how important do you feel the chimerism and the MRD concur with each other? So how important do you feel?
I think chimerism is going to be quite important. And again, as you said, the MRD marker. So for example, if you've got something like BCR-ABL, which you can quantify very easily, I think here the BCR-ABL is going to trump much higher. And also the split MRD is going to be important because a lot of it is, whole blood MRD. So what your CD3 is. So I think those, because it will have to be taken both in conjunction. You can't take them in isolation. So again, it's going to depend on your clinical context.
So I think all these three tests have to be together. I do a flow MRD, I do a NGS MRD, and obviously look at all the others, the clinical situation, and then you take a decision. And this concept of ignoring the DTA mutation post transplant doesn't make sense. It doesn't make common sense because you really have to follow the DTA mutations, see if the VAF level is increasing. It means that your marrow is under stress. And with the stressed marrow, you're going to get some detrimental outcome at one time or the other. So if you really get a DAT mutation and you don't want to do DLI or azacitidine, in fact, you can now add venetoclax with maybe, you activate the MCL2 pathway with glitatinib. So there is a good maintenance therapy with venetoclax, glitatinib, and azacitidine post-transplant if the body can take it. So, all this can happen. But if you're not going to do it, are you going to completely ignore the DTA mutations? It's something to really ponder about because, the marrow is definitely under stress. You want to follow it up, see if the VAF levels are increasing, and maybe intervene when it is increasing. So one NGS is not enough. So we do it every 3 months, and we do all the three tests, the chimerism, flow, and this thing. As Shantanu said that you will get a subset of patients, almost 20-25% of patients, where MRD is positive. In fact, in the last MRDCON, we showed a patient like that, if you remember 2022. Chimerism is 100%, we give DLI. Chimerism is still 100%, but the pre-transplant mutations are still there, which includes a KRAS also. What is it? It's already given in the many cycles of DLI. He has had a year of anxiety, 2 years of therapy. So what are you going to do with that? But in conjunction, the three tests gives you more information than a single test, and obviously if done serially. Again, there are logistical impacts of that. So as I said, minimal residual disease is not minimal really. It is a measurable residual disease, and it is more of a concept. So this whole conference is a philosophical concept rather than a objective outcome.
I think I take your point, but I would still we've debated quite a lot, and I think unless we have an actionable marker or an actionable thing to do with that positive result, I'm quite skeptical in using a test just for doing the test or knowing something unless I know probably because I personally believe if we have a good flow MRD and a good split chimerism, and that I would stress on the role of split chimerism because you can act on it. So if those tools are sitting at 100%, then I would probably ignore DTA. We've done quite an extensive review for literature and our data set in Princess Margaret and Toronto as well. And acting on a DTA is quite difficult because it's also a concept of the donor-derived mutation. So you don't know what you're dealing with. And it's even if it persists at a low level, it's not shown to change outcomes. So I would be very wary of acting on DTA mutations. That's one. And second is, and even for NGS MRD, unless I have a plan B in mind.
I think.
Yeah. Let us conclude the session, and thanks Amir and all the panelists for taking part in the discussion.
Thank you.
Thank you, panelists. Thank you, moderator, for the great session. I would request Dr. Anil Aribanti to be with us for the next session as well. Yes, so we have a talk on manipulation of stem cells by Dr. Joydeep Chakraborty. May I request you on stage, sir? Sir, would you kindly introduce Dr. Chakraborty to the audience?
Come, Joydeep, come. Again, Joydeep, I know him for past 20 years actually. He was 1 year junior to me in Manchester. Then after that, he moved to London, I think, Royal Free London or London Barts for his hematology training. He did his transplant training in Hammersmith. And we came together in 2012. From our group, he's the most brilliant chap. And he conducts all these, conferences, MRDCON conferences. I'm more clinical. And Jaideep, take this.
Anil Aravandi, thank you for his kind words. It was Anil's 25th wedding anniversary yesterday. So if you can all give a clap and congratulate him for that. So I'll start off. Thank you for the kind words. So we'll start off with graft manipulation. And as you know, Gaurav was saying in the other hall that graft manipulation means that we do something with the graft to change the graft, whether it is in vivo, whether it is in vitro. So what is this? Anyway, so what we were trying to do is all the cellular elements that they are there, which is going to give us the graft versus leukemia or the graft versus malignancy effect. We are trying to do something to all this so that we don't have too much graft versus host disease, yet we have a lot of immunity against infections, against relapsing cancer, while on the other hand, we also have a hassle-free transplant as such. So that is what we want to do. So here, what we want to do is obviously reduce the volume, so that we have already done. If you've got antibodies, you reduce red cells, you plasma exchange, reduce volume in a pediatric transplant. So much volume is not needed. You reduce the white cells, you completely get rid of lymphocytes at that time. And how do you do that? You can either do it by taking the whole of lymphocytes out, be careful about graft failure with that, or else you take some of the lymphocytes out or a specific type of cells in out. So you can either take it out, or you can negatively select. For example, you negatively select your alpha beta T cells, or you positively select. So you positively select your stem cells, your CD34 cells. So, HSCT it gives us a platform. So all the cellular therapy, the CAR T cells, whatever we're thinking of, the NK cell therapy that we used to do during transplant, and we have done a few haplo NK cells also without the transplant setting, exclusive of the transplant setting. All this comes from the concept of the hematopoietic stem cell transplant, 1956, the first done by Sir Donald Thomas. So we are all carrying on in that legacy. So as you can see in this, what we can do, what are the things we can do is obviously the natural killer cells, the gamma delta T cell infusions that we can give. We do take the TCR out, and we haven't come to that as of yet. We were talking about gene editing in the morning in the CAR T cells. So that is something we can think of with our, CRISPR-Cas9 technology. We can give specific type of leukemia-specific leukemia-antigen-specific T cells. And in fact, we are doing it for the viral-specific T cells also. And if they go wrong, we have a suicide gene incorporated with them. The cells will die without giving any GVHD. And obviously, you allodeplete, and that takes care of the HLA barrier also, if you can do that. Mesenchymal stem cells. So all this we can do in manipulating the graft. But the first thing that happens is that even before taking the graft, what you can do is to how you are mobilizing the cells. And this is our data of giving Plerixafor to all our donors. So what happens is that if you give Plerixafor to the donors, your natural killer cell or CD56 bright T cell increases. And that would most probably give rise to better better peri-transplant period, mainly with infections, and also a little bit of graft versus leukemia, not a little bit, also quite a bit of graft versus leukemia effect, especially in the AML setting. So initially we were trying with low dose decitabine and we were not getting very much. And then we started, sorry, not decitabine, plerixafor. And then we started doing quite a bit of double dose plerixafor, and our CD56 counts were much better that way, bright CD56 counts. Now, if Dr. Pranati Gupta is here, she has the rest of the data. If she can, corroborate that, and we can go on writing this up. What we have seen with that is that it also increases the amount of the plasmacytic dendritic cells here. And with the CD56 and the plasmacytic dendritic cells, we are trying to get a graft which almost resembles a bone marrow graft rather than a peripheral blood graft. Have you got any evidence of that? I must say our GVHD data is much less. So we do more haplos than many other centers. And what we have seen is we are seeing an acute GVHD grade 3 to grade 4 of less than 5%, and a grade 2 to 3 of less than 10 to 15%, and chronic GVHD of again, less than 10%. So is this doing that? That might be one of the things which is doing that. We obviously take our GVHD prophylaxis very seriously. So this might be one of the things of graft manipulation, in the donor itself. So we'll talk about this boy who was referred to us from Mumbai by Dr. Balakrishna. And this boy is still doing well. He was initially diagnosed with a T-cell ALL, had BFM induction, MRD was positive, hyper-CVAD. After hyper-CVAD, he had blast in the peripheral smear. When he came here, we saw that he had 3 clones, a lymphoid clone, a B lymphoid clone, a T lymphoid clone, and a myeloid clone. And as expected, we got, I think, a KNMT2A mutation here, and also a fibroblast growth factor mutation here. That was important. This was a complex karyotype that we found out in the cytogenetics of this boy. So that was very interesting, the way we decided to reinduce or decrease the blast counts. As Samir was saying, that in refractory leukemias, you sometimes have to go ahead with a transplant with lots of blast cells in it, and we call it the sequential allograft. But here we decided to go ahead with reducing the blast counts, and we use venetoclax, obviously taking the BCL2 axis, ponatinib for the fibroblastic growth cells, blin for the CD19, and we gave a little bit of cyclovinc with bortezomib for the T cell. So bortezomib is now, especially the relapse refractory setting, bortezomib TALLs, we can really need to think about using bortezomib there. Anyway, so after 3 weeks, what we find is that the B cell clone has gone. As expected, we use blinatumomab. You really don't see a B cell clone after that. Interestingly, with the ponatinib and the ven, the myeloid clone was gone, and we had a little bit of a T cell clone. So yes, please, I would recommend to use not only a flow pre-transplant, but I would definitely use the NGS pre-transplant also. And if I'm not confident of doing a sequential transplant, I would try to get the MRD to go down as much as possible before we can go ahead. But in this case, I don't think we could have done it much further without harming the patient. So we decided to go ahead with the transplant. And what we did was we did a sequential transplant as the MRD was positive. This was a Hammersmith protocol, which is basically the Flamzeric protocol. And we know that if you use a Flamzeric, you get a better outcome. Look at the leukemia-free survival in the middle lower curve there. You've done the rate of relapse if you're using this kind of thing. My experience with Jamie was a sequential allograft where you used to use very high doses of cytarabine, which used and daunorubicin, which used to call it Vancouver DA. And then people who have been to Vancouver, they apparently use this. And you then go ahead and do reduced intensity conditioning transplant on the back of that high dose chemotherapy. But more patients used to die rather than live. So, you need to keep a patient alive also. If you're going to do all these things, the first thing to do is to keep your patient alive. So well, we use a lot of clofarabin in our sequential allografts, and perhaps there are some German papers which is now showing almost a 45% leukemia-free survival with the use of clofarabin in this setting. So can we separate GVL from GVHD? Clinimax is a way forward. And what you do is you do a TCR alpha beta, a CD19 negative selection, and you basically also take out quite a lot of your CD45 RA cells. So what you have is a CD4 is memory T cells which are CD45 RO positive, and you keep that for your MDLI. So that MDLI, I'll come to it when you go there. So this is MDLI infusion, which is CD45 RA negative, RO positive. And what it does is that you can give it prophylactically, or you can give it as and when needed. But we tend to do some prophylactically with that, especially that decreases the viral response. It helps the patient mount a viral response against all the viruses that we see, mainly CMV. In fact, we saw it for a COVID patient also, day plus 15 Delta wave, and the patient had bad COVID. We used it for that COVID patient. A couple of patients, I think we used it for, and it worked very well. So MDLI is a way to go forward. Remember, what is this? Remember that this is the NK cell anyway. So remember that with MDLIs, there's still a chance of graft versus host disease, but the chance decreases much compared to normal DLI. So these were the doses of the cells that we gave him. This is the lymphocyte dose. Anyway, so the patient presented had a uneventful transplant, went away, but came back with a very high BK virus positive hemorrhagic cystitis. And again, we started giving MDLI at increasing doses. These are the doses of DLI that we used, and you can see we have gone up to 23.9 million cells at a point of time. So we've used a lot of MDLIs in this patient, and he's doing well for now. This is another patient, and this patient had COVID. And after COVID, we didn't know that this patient had COVID, but we saw a graft, almost an impeding graft failure where the chimerism went down to 80%. And you can see that after the MDLI infusions, the doses are also given, are there? Yes. So we now have 100% chimerism. In fact, we still have 100% chimerism on day 839, which was last month. So 10/6/24, yeah, last month we've got 100% chimerism. So you can see this is a very important tool to have. And if things are going wrong, some stem cells and some DLIs, if you can have in hand, is quite good. But you have to counsel the patients that they spend money for this. So give them the utility of this. And this is not going to go to waste, because here you've got a product which you can definitely use safely without getting very worried about graft versus host disease, and use it as a prophylactically, administer this prophylactically, even to have better disease control. This was a patient, I think, had 2 doses of DLI for COVID. He is doing well. So the DLI immunotherapy, we can use antiviral T cells, so that again, we can develop T cells against CMV, against viruses. Again, it takes around 3 weeks. We take cells from the donor, and we can do that. It takes around 3 weeks to develop. So for a refractory CMV, you need to get the patient going for 3 weeks before you can use that. It's very useful in EBV, in the EBV setting. We have used it no, we have not used it. We have used it in the CMV setting only. NK cells. So again, the NK cell infusion is something which we have been practicing for a long time now. And we have been using it in the allogeneic transplant setting, mainly in the haploidentical transplant setting. But what we have done also is we have used it by just lymphodepleting and giving an NK cell infusion with interleukin-2, with the high-dose interleukin-2. We have done it in 2 patients. One is a 74-year-old man and AML as a consolidation post-transplant, all under the umbrella of a trial. And that patient has done very well. In fact, he is on azacitidine and venetoclax, and he has developed his own regime of doing venetoclax. So he sees that his blood counts are going down if he is taking every day or even alternate day venetoclax. So he takes twice a week venetoclax. Whether it's doing anything or not, we don't know. But he is fine. He's absolutely fine. And the other patient has got CML blast crisis, but didn't do very well. Again, CML blast crisis is a nasty disease, and maybe whatever you do, things don't work very well. So thank you very much. Any questions?
Jaideep, when you said plerixafor, do you give it to the donors when you collect the stem cells? All normal donors. Okay. Mhm.
So we use 0.24 mLs 4 hours before collection. So that is the peak when you have the peak. Just 4 hours after that, you have the peak of your CD56 bright NK cells. Now, there is a downside to it. It's all not rosy. We had one patient, we were doing a Clinimax transplant, who passed away with profound CRS. I've never seen such bad CRS with interleukin, 6 levels greater than 50,000. And whatever we didn't bring the patient back. So are my NK cells responsible for that? That is something we need to think about. So if it is so, what is the cutoff of NK cells that we are aiming for? So those are things that we still cannot answer, but that is one case in many which had this profound CRS. In fact, I was talking to my colleagues, there will be some patients where you will get this CRS, HLHs, and you really don't know why. Maybe that is where we need to do a exome sequencing or in fact a genome sequencing in these patients to find out that who exactly will have this kind of immunological reaction post-transplant. What we are trying to do is to gather data and see if we can determine it with machine learning. So we have got almost 30 to 35 variables for CRS or HLHs during transplant. And if we can use a machine learning algorithm to predict that which is more important or not, I think that will be very useful to know that before we go ahead. So, we have done a similar one for veno-occlusive disease. So if we can keep the same kind of concept and take it for CRS, I think that might work. Let's see. So Sitaram, you were asking about the DLI doses. You see that. So we go on an incremental dose. So we know one DLI is not going to be enough, really. And there are many papers suggesting that you need to go on an escalating dose of DLIs. And if you can do your MDLIs, I think you can more safely give DLIs. In fact, what we do is we first lympho-reduce the patient by giving bendamustine for 2 days and then give the DLI. So that's worked so far. Let's see how we go. Okay.
Any other questions? Thanks, Joydeep.
Thank you so
Thank you
much.
for the excellence.
Thank you, sir. Thank you, Dr. Arivanti, for your presence. We are actually running ahead of time. We still have 10 minutes to our panel discussion. In the meantime, you can just freshen up. And after our panelists arrive, we will start the discussion at 3 sharp. Thank you. Persons in this next session. This will be a panel discussion on maintenance therapy post allogenic SCT. I would request on stage the moderator, Dr. Tufan Kanti Dolui, hematologist, Ruby General Hospital, Kolkata. I would request the panelists, Dr. Rajat Bajaj, consultant hematologist, hemato-oncologist, and bone marrow transplant physician, Dr. Anil Aribandi, sir, Dr. Manthan Katrotia, consultant hemato-oncologist, Apollo Cancer Center, Ahmedabad, and Dr. Balkrishna Padate, Director, Center for Hematology and BMT, Nanavati Max Super Specialty Hospital, Mumbai. Handing over the session to the moderator. Welcome, sir.
So I think this is the end of this session of the hall A. That's why the audience is very thin. But at outset, I thanks to the ACG and Dr. Joydeep and Dr. Odijit for the inviting me for giving this the panel discussion of this the maintenance therapy of the post allogenic stem cell transplant. You know the maintenance therapy is very important in allogenic stem cell transplant because sometimes the patient has a several problems, particularly related to the disease. In the transplant, there is a lot of the problems related to disease also. But before that, we'll be discussing the issue of the maintenance. And we have the panelist is there, Dr. Rajat is there, Dr. Manthan is there, Dr. Balkrishna, and Dr. Anil is also joined. That is great, Dr. Anil. So with this great panelist, Dr. Rajat is from the Nagpur, Dr. Manthan from Ahmedabad, and Dr. Balkrishna from the Mumbai, and Dr. Anil also. So to begin with, you know the main cause of the failure of the allogenic stem cell transplant is mainly the two reasons. One is the disease relapse, and another is the non-relapse mortality. So in terms of the non-relapse mortality, there is several complication is there. So we'll be not discussing here. So we'll be little bit concentrating of the prevention of the disease relapse. So there is a main role of the maintenance therapy of the coming. So the important thing is that in terms of the factor that influences the risk of relapse of the disease, basically these are the three important aspects we'll consider for before putting the patient in the maintenance. So here is the role of the panelist in terms of the factor that influencing the risk of relapse after the allogenic stem cell transplantation. These three factors we think we will considering in our day-to-day clinical practice. So we can go to one by one from the Dr. Rajat first. So what biological factors that have been important for deciding the putting in maintenance down the line?
So yeah, like your slide show, the most important factor is the disease biology. If the disease is high risk to begin with, the disease has got some high risk mutations, and that is the most important factor, I think, in predicting the outcomes post transplant. Second is the disease status at transplant. If the patient is not in CR, or if the patient has MRD positivity, Dr. Samir showed the curves. There is a stark difference in the outcomes if the patient is MRD positive pre-transplant. And yes, and the transplant related factors are also play an important role as to the age of the patient, the marrow reserve, the type of conditioning used, and
right.
Yeah, and
So the lot of the factor have been important in the biological risk of the disease means the before the transplanting that was the condition of the disease. Means is the condition that the high risk is there, the blast percentage is very high, there the high risk mutation is there. So a lot of the other high risk factors is there that can deciding one factor. The second important issue is the MRD status. So go to Dr. Manthan. So how is the role of the MRD status before deciding the maintenance therapy?
Now, in acute leukemias as well as in lymphomas, everywhere it is shown that patient having MRD negativity proceeding to transplant has the best outcomes. So any patient who is not able to achieve MRD negativity for that particular disease definitely has a high risk of relapse and requires some kind of maintenance therapy post-transplant.
So the MRD is very, very important. We have been heard about the MRD in the just the 1 to 2 lecture previously. So the MRD has an important role, not only the putting in the transplant, before putting in the transplant, but also the down the line of the transplant. Next, the important factor that deciding in the maintenance therapy is the intensity of the conditioning regimen. So Dr. Balkrishna, what is your take point in this issue of the intensity of the conditioning?
So reduced intensity conditioning transplants, those are the patients primarily would be considered for maintenance therapy post-transplant. Patients having high intensity transplant, their relapse risk related to the disease is lower than patients in reduced intensity conditioning. Patients having immunologically modified conditioning regimes, those are the patients who have slightly higher risk of relapses post-transplant compared to patients having radiation-based transplants. So those two category of patients are generally considered for maintenance therapy proactively and also intensive monitoring post-transplant.
Right, absolutely. So the malleability conditioning, usually the maintenance is less questionable, but the nowadays the recondensed conditioning and the other conditioning, they have an important role of your maintenance. Now go to the Dr. Anil, that is a very, very important. So our idea is we need to prevent the disease relapse because we did the transplant, but down the line patient should be cured from the disease. But unfortunately, there is a chance of disease relapse always there. So what are the different strategy we can go to prevent this disease relapse? Dr. Anil, please.
Again, as we are discussing about maintenance therapy, here maintenance therapy, where do we give? First, someone who is at high risk for relapse, definitely what we have discussed before, someone with high risk for disease, biological disease, reduced intensity condition, and someone who is MRD positive. These are the patients, there is high risk of relapse around 40%. So these are the patients we take for maintenance treatment. And when you say maintenance, these maintenance treatment is given when patient is in CR. Therefore, the patient is not, he doesn't have any disease. That is what we call maintenance treatment. And usually started around after, I think, most of the literature says around 30 days after transplantation, you can start the treatment. The second type of treatment is preemptive treatment. When you say preemptive, someone who becomes MRD positive after transplantation, that is the time you introduce the treatment, like DLIs and other stuff. Third one is when patient has frank relapse. That time you can start the treatment.
Right, Dr. Anil is absolutely right in that aspect. So there is 3 different approaches in there for to prevent the disease. I already mentioned. If we have a disease, then we have to treat as early as the possible. Second thing is the preemptive therapy, means there is a detection of the MRD is there, then we have to treat the disease. So after the post-allo transplant, we have to continue follow for the minimal residual disease. If there is a positivity of the MRD, then we have to initiate the treatment as early as possible. And the third category, that is the maintenance therapy, means that a post-transplant, if the patient is molecular CR, then only there is a role of the maintenance therapy is there. So this is in the complete remissions and also the molecular remission, then there is a role of the maintenance therapy. So the maintenance therapy is initiated when the patient is complete remission. Preferably it will be into the molecular remission. That will be the very, very important thing that has to be considered. So we are discussing the different factors. So to deal with this, the factor that influence the decision making to initiate the maintenance therapy after the allogenic stem cell transplant, these are the 4 and the 5 important aspects that you should think before initiating the transplant. So one and foremost important thing is that the underlying disease, as we have been already discussed, if the patient has a high risk disease is there, then we need to initiate the patient on the maintenance therapy. And also the MRD positivity, this is the trigger for you initiating the maintenance therapy. If the patient have been given the RIC conditioning, this is the also trigger for your the maintenance therapy. And also if the patient has a post-transplant, there is a slow hemopoietic recovery and ongoing your infection, toxicity and the GVHD, that also the important factor for initiating the maintenance. And the more important thing is that targeted agent. That targeted agent is basically based on your the molecular abnormality. If the patient has a molecular abnormality is there, if the drug is available for that kind of scenario, then only we can target it. So these are the 4 to 5 factor becomes important for before choosing the patient into the maintenance therapy. So in terms of the different diseases, there is several diseases is there. We can put the patient on the maintenance. So I have been shown into the list of the diseases. There is the AML, MDS, there is the CMML, the Ph positive ALL, the CML, and also the BCLL, and also the different non-Hodgkin's lymphoma if you do the allogenic transplant. T-cell leukemia, lymphoma, and also the multiple myeloma if and do the allogeneic stem cell transplant. Though the very less number of the patient we are doing the allogeneic stem cell transplant in multiple myeloma. But we'll be discussing only the three important, the common we encounter in a day-to-day clinical practice, that the AML, MDS, and also the Philadelphia positive ALL. So there will be three cases is there. So we'll be discussing the three cases one by one, and then we can go ahead. So this first case go to the Dr. Rajat. So here is a 64-year-old man presented with a new onset fatigue and also the dyspnea. WBC count is there is 56,000. Hemoglobin is become 7.2. The platelet is 36,000. The bone marrow, there the AML is there. Around there is 70% blast is there. And cytogenetics is there. No abnormality have been detected. But in NGS, there is a DNMT3A positive and also the FLT3 ITD is positive is there. The NPM is also the wild type. Patient have been given the 3+7. There is the daunorubicin plus cytarabine as we have been given along with the midostaurin. There is the 50 mg twice daily for the day 8 to day 21 and patient achieved the CR. After giving the another 2 to 3 cycle of the HIDAC therapy, then there is a unrelated donor is available and planning to do the rig transplant in these patients. Meanwhile, we repeat the NGS. In the NGS, the FLT3 is negative, but the DNMT is still detectable. So in this case scenario, after the stem cell transplant, before the transplant, that the FLT3 is negative, but DNMT is positive. So any role of the post-allogenic maintenance is there, Dr. Rajat?
So for FLT3 acute myeloid leukemia, there is an established role of maintenance TKI. So post-transplant, I would probably do FLT3 PCR just to see where the patient is at, and then continue him on any of the available FLT3 inhibitors for an year with 3 monthly monitoring of FLT3 PCR.
Right. Though the patient has a FLT3 negative, but you know the FLT3 is the bad mutation. We usually see in around 25% of the cases of the newly diagnosed AML, and patient has a FLT3 ITD, has a propensity to develop the early disease relapse. So in that scenario, even after the allogeneic stem cell transplant, around the 30 to 40% of the patient will relapse. So even in case of this MRD negativity, there is a role of the maintenance therapy, as Dr. Rajat is rightly pointed out. So what are the different agents is available in FLT3 mutated patient, Dr. Manthan?
So various FLT3 inhibitors have been used. The most frequently available in India are midostaurin and the old good sorafenib. At present, the data is coming up about gilteritinib, which is the most effective FLT3 inhibitor in post-transplant maintenance in preventing the relapse. But unfortunately, it will be available soon in India. Right now, it is not available. But data suggests use of gilteritinib. It is a FLT3 inhibitor.
So we have a 3 to 4 option is there in terms of the sorafenib, the midostaurin, and also the clonazepam, and also the gilteritinib. Lot of the other product is also going into the trial. So which agent is preferred? Dr. Balkrishna, what is your take in this point? Which agent you prefer in your clinical practice?
Sure. So sorafenib and midostaurin, both of them have significant data so far in post-transplant maintenance MRD negative patients, even if they are FLT3 negative. Gilteritinib is used first line in patients who are FLT3 positive pre-transplant. Post-transplant data is just coming. Drug is extremely expensive, and that is the reason we don't have access to this drug. But I have used both sorafenib and midostaurin. Midostaurin has excellent data post-transplant, which is used for 2 years. Day 1 to 14 in some patients, tolerable patients who can tolerate. Day 1 to 28 also we have used. Common side effects are gastrointestinal side effects. Sorafenib I have used in 6 patients so far. In Indian setting, in fact, that data is more mature in sorafenib compared to gilteritinib. So at least there are 3 or 4 randomized phase 3 trials to show benefit of sorafenib in post-transplant patients. Only issue in Indian setting is that higher risk of reactivation of tuberculosis and active monitoring for tuberculosis, particularly in patients who previously had tuberculosis, might need maintenance with anti-tuberculosis medicine while they are on sorafenib. That must be kept in mind. Both overall survival and PFS benefit is there with sorafenib as well as in gilteritinib. The third agent I have not heard and used before. And the last one, what did you say? The last one?
The fourth drug is there.
Yeah, sure. Okay.
Dr. Anil, you have any question or comment?
I mean, evidence-wise, there is only evidence for sorafenib right now. There are 2 randomized trials. One is SORMEN trial and one is Chinese trial.
they have shown clearly that in Sormen trial, they're given for all patients, they're given sorafenib for 2 years. And for the Chinese trial, they're given for 6 months. And what they've shown is leukemia-free survival was around 80% who is on sorafenib and 50% for the other group, placebo group. I think midostaurin, we don't have evidence for the benefit. And even gilteritinib, only MRD positive patients, it was beneficial. But I think overall survival was not there with that agent.
Right. I think both are true. In terms of if we go to the evidence, in terms of the evidence of the sorafenib, the Sorafenib trial has become mature data is there. And that data have been clearly shown us that yes, there is advantage is there by giving the maintenance. In terms of the midostaurin, people also uses the midostaurin in terms of the maintenance. But if you consider the published literature and the data, the midostaurin is not so much effective, but you can give it, but not so much effective. Data has been not in favor of giving the maintenance. It does not prevent relapse. So midostaurin is questionable. In terms of the quinolone and also the gilteritinib, there is ongoing result is going on. The trial becomes going on. In terms of the gilteritinib, as Dr. Balkrishnan rightly pointed out, the early data is very encouraging. So in terms of the gilteritinib, you can use this gilteritinib as a maintenance also, particularly MRD positive, as Dr. One is rightly pointed out. So right now, the sorafenib is the drug you can use it, has a data, but other drugs, particularly the gilteritinib and also the quinolone, they are evolving. In terms of the when to initiate the stem cell, when to initiate the maintenance and how long you have to continue. Doctor, I think Dr. Anil have been given the answer. Anil, this is directed to you only. So how long, how to, when to initiate your the FLT3 and how long you should continue?
The idea is to start after 30 days. And we have to continue for a minimum period of 6 months, as in Chinese trial. But ideally, we need to continue until 2 years, as long as patient can tolerate the tablets.
Right. So, Dr. Rajat, so in terms of this, the monitoring, so how do you monitor this patient and what are the methods you can use in your clinical practice?
So flow is always there, but if we have a FLT3 mutated disease, I would probably monitor every 3 months using a FLT3 PCR.
Right. You can also do NGS also, but yes, the PCR is the right method. And every 3 monthly, you should monitor the patient, and the drug has to be continued for at least 2 years. Agar in between, if it is positive, then what is your action? Suppose your this FLT3 is positive, IDT is positive with your PCR. Then what will you do?
Well, the other option is DLI, obviously, if there is no GVHD. And maybe if I think gilteritinib as monotherapy has shown some advantage for frank hematological relapse.
Right.
So if the patient is on sorafenib, midostaurin, then I would consider giving some DLIs and or switching to
Right. So absolutely right. So first that we have to confirm it, reconfirm it, whether this might result of the FLT3 positivity is really positive. So you have to repeat the test after 1 month. So if it is still positive, so in that scenario, we have a 2 to 3 option, as Dr. Rajadis rightly pointed out. And in terms of this, the ongoing result, if you go to the clinicaltrial.gov, that this 2 trial is going on in terms of the gilteritinib and also the quinolone. The gilteritinib is because phase 3 studies becomes going on, and also the quinolone is the 2 years. So in terms of the FLT3 mutated positive cases, before the putting patient with allogenic transplant, if it is negative, in spite of the negativity, post-transplant from the day 30, you have to start the FLT3 inhibitor, and preferably you have to continue for at least 2 years. And there is a frequent monitoring of the disease status. But yes, you need to counsel the patient properly, because sometimes patient may be relapsing down the line. So the monitoring becomes very, very important even after the completion of the 2 years of the FLT3. If the patient has a IDH mutation also, in that same scenario like this, the FLT3 cases, we have to be continuing the drugs. Drug has to be started from the day 30, has to be continued for at least a year. You can continue for the 2 years, but at least a year. And these are the trial becomes going on. There is the enacitinib and also the ivosidenib. This trial becomes going on. So I think the long-term result becomes yet to come in terms of the IDH mutation cases. Next, come to the case number 2. So the case number, Dr. Mamsan, please. So the 51-year-old man presented with a new onset dyspnea. Patient has a CBC. The WBC count is very high with a 16% of the blast. Platelet count is 35,000. Bone marrow, there is a B cell ALL is there. There is a 70%. There is a lymphoblast is there. Cytogenetics, there is a translocation 922 is there. and there is a BCR. The P210 is there, so possibly it is the CML progress to the blast crisis. The BCR-ABL fusion transcript is there, and patient have been treated with the hypersevere chemotherapeutic regimen. And we did the MRD also, but during the hypersevere, we have been given combination of the dasatinib also in these patients, and patient achieved the remission. But there is a persistence of the MRD in the flow cytometry. Then subsequently, patient have been received the 1 cycle of the blinatumomab along with the dasatinib. Now the patient becomes the MRD negativity. Then plan to proceed the myeloablative allogeneic stem cell transplant from the matched sibling donor. So in these cases, what is your role in terms of the post-transplant maintenance?
So this is a very high risk ALL. As we all know, BCR-ABL positivity makes it very high risk, and the patient required multiple lines of treatment to become MRD negative. So he should be put on TKI post-transplant. One factor that should be considered is to check for any mutations related to tyrosine kinase domain, and if they are there, then TKI should be changed accordingly. Otherwise, imatinib or dasatinib both are preferred agents for the maintenance.
Yes, I think the Manthan is absolutely right. In terms of the agent used to treat the pH positive cases, there is a option is there. I will giving there the imatinib is there, the nilotinib, the dasatinib, the ponatinib, assimilate. These are the agencies available. In terms of the preferable and why it is preferable, there is a lot of the debates and there is a lot of controversy is there. In terms of the data, if you go to the long-term data, imatinib is there. And also the little bit the dasatinib data is also there in terms of the long term. But yes, as Dr. Manthan rightly pointed out, you have to do the TKI mutation study. Depending upon your sensitivity, you can go ahead with any of the TKI because the data becomes not mature enough to tell us the selective agent. Suppose patient is developing down the line that there is a T315I mutation positive. So obviously in that cases, the imatinib, nilotinib and the dasatinib is not going to help in this patient. So you can use either the ponatinib or the dasatinib, you can use it. So as Manthan is rightly pointed out, we have to do the TKI mutation study and then subsequently we have to give the another TKI for this patient. So in terms of the similar question, when to initiate after the transplant and how long you should continue, Dr. Anil, you have any question or comment in this issue?
Yeah, you start after 30 days and as long patient has been taking dasatinib and he has been tolerating well, we can introduce the same drug. But I think data showed nilotinib is very toxic. I think there are a lot of side effects. Imatinib, I would prefer more dasatinib than imatinib, practice mostly because it prevents CNS relapses actually. And if there is a mutation, then we think about ponatinib. Yeah.
Right.
And
So
continue. I mean, they say literature says up to 2 years, but I would continue.
Continue the lifelong, indefinitely. Indefinitely. So Dr. Balkrishna, what is your, in terms of how frequently you should monitor and which method you should choose it?
So every 3 months, we definitely do quantitative PCR. Like all other transplant patients, they would get MRD monitoring as well for the background ALL status. And of course, quantitative PCR you would do for BCR-ABL. And what Anil said is right. Although all the data says 2 years, most of our patients themselves also don't want to discontinue.
Absolutely right. So we have to continue the lifelong in spite of the negativity because your drug is available and also the patient himself will be continuing or herself will be continuing the fear that they might get relapse down the line. So you have to continue, but data is at least if your toxicity allows, you should continue for the 2 years. Sometimes it is very difficult to continue the TKI due to the frequent problems. Suppose patient has it, we have been giving the dasatinib, patient developed recurrent pleural diffusion. So what will you do in this scenario? We can change the other TKI also. But if the other TKI, they have also the toxicity. So in that scenario, their suggestion is that at least you should continue for the 2 years. But if patient is tolerated, then you should continue the indefinitely or the lifelong. This the trial is going on. If you can, if you can participate also. This is the dasatinib trial in case of the post-transplant maintenance. This is the third case. Go to the Dr. Balkrishna, please. So the 69-year-old woman found to be have worsening anemia. The hemoglobin is 7.5 and the thrombocytopenia is also there. Please project the slide, please. Screen, please. Yes. So the 69-year-old man found to be have a worsening anemia. The hemoglobin is 7.5. The platelet is there is 42,000. and the bone marrow examination. So there is a consistent with MDS with excessive blast. There is a 15% blast is there. Cytogenetic, there is a complex karyotyping is there. The NGS we did, there is a point mutation in the TP53 gene, and there is a VAP is 43%. Patients have been treated with 4 cycle of the decitabine with improvement of the hematological measures. The repeat bone marrow biopsy, there is only the 2% blast is there along with the normal karyotyping. But yes, this genomic analysis, the NGS repeated, there is a persistence of the TP53 mutation, but VAP is decreased to the 7%. And then we are planning to do the transplant in this patient by the reconditioning from the match unrelated donor. So in these cases, what is the role of the post-transplant maintenance?
So all patients with TP53 mutations, both in AML and MDS, irrespective of whatever post-transplant maintenance you do, they do poorly. If the persistence of TP53 is there, those patients who become negative at the time and post-transplant, those are the only patients who do well with the maintenance. So of course, you are going to use the maintenance with azacitidine, decitabine, combination of azacitidine, decitabine with venetoclax, whatever is at your hand. But these patients still do very, very poorly. Now, as far as the data is concerned, there is azacitidine single agent, IV and oral both. Although azacitidine oral, the data is only in pre-transplant patients who have achieved remission, not in post-transplant patient. IV azacitidine, there are 2 sets of trial. One has suggested definite improvement in patients with the maintenance. However, one trial suggested that they have more toxicity when you use on 28 daily cycle, and there is no benefit in terms of the maintenance. There is a use of decitabine in combination of venetoclax and decitabine in combination of GCSF. That is a Chinese trial. It has shown significant improvement in patients when you are used for 6 months of decitabine with GCSF in terms of outcomes of patients in any set of AML, but poor responses in patients with TP53 mutated patients. Oral HMA not useful in post-transplant patient, or we don't know the data yet. It is used only in pre-transplant, non-transplant setting. Azacitidine plus gemtuzumab, I'm not aware of any trial that combination being used for maintenance in TP53 post-transplant. So I'm not aware of that, but other two I can talk.
Dr. Anil, in your practice, which agent do you use?
So tolerability is the main issue. And the other, I think there is a trial, phase 3 trial for oral AZA and venetoclax. I think we're waiting for the results. But main thing is patient tolerability with these medications is the major issue.
Right, absolutely. So we have to use the one of the hypomethylating agent maintenance, that is sure. So the agent of choice is basically dependent on your toxicity and also the depending of the availability. There the trial is going on in the other side, and also gemcitabine. The early result is very encouraging. That's why I've been put in the trial. So either agent you can use it, but the oral hypomethylating agent, the trial is going on. So different trial is there. I'll be showing in the subsequent slide. But same question is when to initiate the maintenance and how long you should continue. Doctor,
I think as early as
yes,
possible, day 30, and then continue for 1 year.
Right. So at least you should ideally after the complete recovery, you should use this trial. So you use these drugs after the day 30 or the day 60, you should use it. And if your toxicity permit, you should continue for at least in a year. So the hypomethylating agent has to be used in a year. So in terms of the monitoring, Dr. Manthan, what is your in terms of the monitoring in these cases that TP53 mutation?
So we should monitor it by NGS or PCR to every 2 to 3 monthly. That will be the strategy. And if it comes positive, then like sir has told, it has very poor outcomes. Nothing much can be done. The patient should be explained accordingly.
Right. And also you have to do the VAP also has to be monitored, because if it is rising, then there is a problem is there. So that not only to the monitoring, but the VF has to be completely monitored. Otherwise, there is a more chance of the relapse into the down the line. So in terms of this, the hypomethylating agent-based approaches, these are the trial is going on. As Dr. Onlis rightly pointed out, there is a 2 to 3 trial is going on in the azacitidine and the venetoclax into the down the line. There is a phase 3 study is going on into the azacitidine and also the venetoclax, and also the other oral decitabine also trial is also the going on. So currently, the majority of the people, they are using the azacitidine or the decitabine in majority of the setting. But you should remember that this drugs has to be continued for at least in a year, because this is the very important. So we have been discussing the 3 important issues, but what are the other diseases you can go to the maintenance? Dr. Rajat, you can take this question. So what are the different other diseases you can put in maintenance therapy?
So not in terms of allogenic transplant, but say brentuximab is approved for post-transplant maintenance in Hodgkin lymphoma. multiple myeloma, obviously we put almost everybody into some form of consolidation or maintenance for at least 2 years after an autologous transplant. We've discussed high-risk AMLs, Ph positive ALLs. CMLs, obviously there not a lot of CML transplants happening right now, but CMLs, we can consider lifelong maintenance with the TKI post-transplant.
Right. Dr. Anil, what is your takeaway in this aspect? So there's a lot of the trial is going on. So this is none of the approving because all into the phase 1, phase 2 and the phase 3 trial. So I think that down the line, the data will mature and then subsequently we use into the, yes, Dr. Balkrishna, please.
What is the question? Sorry.
The question is apart from the 3 common diseases we day-to-day encounter, what are the other diseases you can put maintenance?
So these ones, and blinatumomab, there is phase 2 trial now to suggest every 3 monthly 4 doses of blinatumomab, and 0% patients had relapses and with good tolerability. So that
Right.
is the only additional thing I would say, but otherwise everything is discussed.
Right.
I wanted to ask you about your patient. What happened to this TP53 patient? How is she or he doing?
So patient is continuing.
Okay, okay.
Patient is continuing.
How many months post-transplant now?
So now it is 1.5 years.
Oh,
so it
very
is
nice.
continuing.
Okay, lucky one.
So, so these are the different drugs is going on. There is the penavinostat trial is going on. Even the lenalidomide trial is also the going on. In terms of the BCL malignancy, the iodine maintenance becomes going on. In T-cell leukemia, lymphoma, there is a romidepsin is also the going on. And as rightly pointed out in the multiple myeloma, apart from the lenalidomide, botensilimab, there is ixazimab trial is also going on in terms of the post-allogenic stem cell transplant. So I'll end here. In the current approaches for the maintaining allogeneic stem cell transplant, as we have been discussing, to summarize that the panel discussion, that if the patient has a FLT3 mutation is there, post allogenic transplant, you have to put the patient on FLT3 inhibitors for at least for 1 to 2 years. IDH mutation also you have to give the ivosidenib and the inosidenib. Into the high-risk cytogenetic, that is TP53 mutation, you should give at least a year for the hypomethylating agent for the maintenance. If the patient has a Philadelphia positive ALL or the CML bronchitis, at least you should continue for at least 2 years. Preferably it is the lifelong. In terms of the other molecular target and the high-risk disease, the different trials becomes going on. I think down the line, there will be the recommendation of this, the maintenance there. And the other diseases, the several other diseases also, they are doing the allogeneic stem cell transplant, but their maintenance is not defined at all. I think the data is become going on, the studies becomes going on. Down the line, we can give some recommendation. So the ladies and gentlemen, the take-home message is the disease relapse is still a leading cause of failure after the allogeneic stem cell transplant. Maintenance therapy administered after the allogeneic stem cell transplant has this promising strategy to reduce the incidence of the relapse and enhance the curable potential for the allogeneic stem cell transplant. But the main problem of this, the maintenance, is sometimes there is a cytopenia is there is a lot of immunosuppression is there. You have to take care of that, particularly the non-targeted therapy. That's why the targeted therapy has been the prefer. And you have to monitor the disease status by the MRD, either by the PCR, by the NGS. And then you can continue the maintenance therapy for the at least 1 to 2 years. With this, thank you for all the panelists for this your views. Any question or the comment from the audience? So we end here and thank you very much for the present hearing.
Thank you, distinguished panelists. That was a great discussion. And the ending one. With this and a heavy heart, let me express what an amazing experience I had hosting such a prestigious ceremony, attended by the best of bests in the field of oncology and beyond. These 2 days of MRDCON 2024, I'm sure we all have gathered knowledge and memories which we are going to make good use of and cherish forever. I would request all the delegates to kindly gather in Hall B for the closing ceremony and the vote of thanks. Thank you all.